Hello, good morning, and welcome all of you to this today's web CME. That's a hybrid CME. Almost 50 people are attending online, and here almost 50 people are there. So today we have gathered here to discuss nutrition in various diseases states from experts in medicine as well as nutrition. So as you know, medicines will help to cure the disease with proper diet and exercise, that is lifestyle. So doctor will treat you your disease, but you have to be your own doctor in taking care of your diet and exercise and all lifestyle. So in particularly diseases like diabetes, hypertension, kidney diseases, so on and so forth, there is a long list. Let us learn today from experts proper scientific knowledge about nutrition. So as you know, IMA Pune is time to time we are arranging series of CMEs and webinars and a certificate course. So you can join that as and when you are available, as well as it's a real need of the time, because you get all recent knowledge as well as the updates. So time to time, it's not like previously, it is to take 8 years to update your knowledge, or recent things used to happen. But now it's a day to day. The next day you get some different story. So you have to be there. So let us be connected with IMA. So today I will introduce first our president, Dr. Meenakshi Deshpande, to give, and she will be, I'll request her to come on the dais to give her a welcome address. Dr. Meenakshi Deshpande, madam. She's our, at present, she's a president of IMA Pune, and she's a chairperson of AMS and Medical Legal Committee. She's a IMA MS Medical Legal Committee member. She's a National Standing Committee. She's in National IMA National Standing Committee, member of Initiative for Safe Motherhood, IMA National Woman, Dr. Swing, West Zone Secretary. So Foxy Master Trainer, Wow Cell, and Foxy representation in PCPNDT NIMC. So she has received many awards. She's got an IMA National Dr. Kanak Goyal Award, President's Appreciation Award in 2017 and 2018, and IMA MS 2019 and IMA MS Award for Best PCPNDT work, AMS work. Then Apulki Award for Social Services, and her areas of interest are antenatal screening, critical care, high-risk obstetrics, menopause clinic, preventive oncology, cancer workup and therapies, adolescent clinics, and medical legal counseling. So I request Madam to give her a welcome speech.
So thank you today. Thank you, Alka. And I welcome you all as the president of IMA Pune to this August gathering of dietitians and our medical officers and our all IMA members. So many of us have joined physically as well as online. And this is a different kind of CME which we are having today. And I hope this nutrition aspect of the day-to-day practice gets boosted, because, you know, most of the times physicians and consultants are very much reluctant to start advising on nutrition because it's a very long topic and patients can keep on asking many questions. So this CME, which is formatted by Dr. Kedar Patil today, so he will be one of the major key holders in this, how to advise on the nutritional aspect in any patient treatment. And I hope this will go a long way in our treatment facilities and strategies which we plan during our patient treatment management. Second thing I wanted to focus is that we are having an UConn now conference, which is coming up 27-28 August. I have told many people who are here to register fast, because the early bird gets over on 30th of June. So UConn is a Women's Doctors Wing conference of IMA Maharashtra State, which we are hosting from IMA Pune, and it will entail a lot of activities and cultural activities also. Second thing is that we are having a good programs which are coming up. So please stay active and stay abreast of the whatever magazines we are sending. We are sending now IMA Plus as on WhatsApp also and by emails also. So if you are not getting our monthly IMA Plus magazines, please let us know by email. So saying these few words, I'll now hand over the mic to Dr. Alka and we will go on with our next program. Thank you all for attending this.
Thank you, madam. आज म्हणायला गेलं तर आज दुग्ध शर्करा योग आहे की नुसतेच डॉक्टर्स नाही आहेत तर डायटिशियन्स पण आहेत. पण ॲज सून ॲज यू ट्रीट अँड यू गिव्ह सम ॲडवाइस टू द पेशंट रिगार्डिंग मेडिसिन, यस डॉक्टर काय खायचं, सो यू नो द थिंग की वी हॅव टू टेल. सो इट्स अ रिअल दुग्ध शर्करा योग. So for that, we have our national president of Indian Dietetic Association, Dr. Jagmeet Madan. She is coming online. So Dipen, can you share her screen? She can share her screen. And I request Avanti Deshpande madam to come here on the dais to introduce her.
Good morning, everybody. Good morning, madam. Good morning, all present here. It's a pleasure to introduce Dr. Jagmeet Madan. She's an eminent nutritionist, a national president, Indian Dietetic Association, principal and professor director, SVT Research, Consultancy and Collaboration Center, SVT College of Home Science, SNDT Women's University. She's a certified nutritionist in low FODMAP diets. She's a gold medalist and a recipient of Young Scientist Award, Dr. Ramanathan Award by the Nutrition Society of India, NIN Hyderabad. She has more than 50 publications in international and national peer-reviewed journals and books. She's and she's also a gold medalist, as I said. It's a pleasure to have you, madam, here, and over to you, madam, for the welcome speech.
Thank you. Thank you for that kind introduction. A very good morning to one and all. A special welcome to Dr. Deshpande, Dr. Patil, Dr. Sancheti Rajan, and my dear colleagues of IDA Pune chapter, Dr. Shilpa Shirole and Dr. Ambika Nair, and her entire vibrant team of IA, Dr. Geeta Dharmati, I think a very vibrant team of Indian Dietetic Association Pune chapter. I'm extremely privileged as a national president of Indian Dietetic Association to be a part of this program. I would have loved to be there physically, but because of certain commitments, I just could not travel to Pune. But yes, I definitely wanted to, give my best wishes and also state the importance of Indian Dietetic Association coming together with other national organizations and especially Indian Medical Association. So, this is a very good beginning by IDA Pune chapter to collaborate with IMA Pune chapter and host a symposium, on a topic which is so very relevant in today's time. We are talking about nutritional management of metabolic syndrome and disorders. So to my mind, I think, we are actually sitting on a time bomb. And when I say metabolic disorders, I am just not looking at metabolic syndrome, which we pretty much identified as a cluster of, biochemical parameters coming together and very rampant in Indian population. And I remember some of our work of our research team, which we did in Mumbai city, way back 4 years back. I think we published this paper and we found the prevalence of metabolic syndrome in adults in Mumbai close to 49%. And I'm sure it is touching 60% today. One of our recent randomized control trial, which we did again in Mumbai city, in older adolescents and young adults in the age group of 16 to 25 years. And we've just published that in Frontiers in Nutrition, June 2021, showed us that the baseline, data revealed that close to 30% of this population was pre-diabetic. And some of our recent work is happening in the field of NAFLD, which I feel is a major hidden iceberg. And I underline the word hidden because, something like pre-diabetes, something like NAFLD, looks can be deceptive. And I'm most concerned about the young adults of this country, because when we did our pre-diabetes randomized control trial, we were astonished that, older adolescents and young adults of this age group who had normal BMI or even lower BMI had so much high percentage of body fat and inflammatory markers in the body and hyperinsulinemia. And they were absolutely normal, leading a normal life. So they were pretty much unaware of what's happening within the body. The same applies to NAFLD, and some of our recent work, which we are just collating the data, in Mumbai, clearly shows that in adults, cut across socioeconomic strata, NAFLD prevalence is to the tune of definitely more than 30%. And that's where I think, we as professionals coming together makes a lot of sense, because I don't have to wait for a person to become a diabetic. I don't have to wait for a person to develop a cardio metabolic disorder. I don't have to wait for a person to go to NASH. Because all these metabolic disorders, which we are seeing, the hidden, layer of this iceberg, can be arrested at a much early age. So I think we as professionals, and it's going to be a teamwork of doctors and nutritionists working together, talking the same language. And when I say talking the same language, we all have to emphasize that we need to screen, we need to detect, pre-diabetes, NAFLD at a much early stage, which means it calls for regular medical checkups, regular, blood parameters done, regular sonography done, liver function tests done. I think these are some of the mandated areas wherein doctors and nutritionists have to come together so that we identify, these cases much early. And there is huge amount of literature to say that all this is reversible. And I again underline the word reversible. So there is no comparison between the logistics of preventing something and curing something. So I think we, today's nutritional professionals, are highly trained, competent, and they are updated with the latest research. And I'm so proud to say that we are spearheading with the National Allied Health Council bill, and nutritionists are designated to be the professionals in this bill, and going forward, this whole profession is going to be further regulated. So what I'm trying to say is that, the doctors, nutritionists coming together is a very, very important synergy and a win-win situation. So I congratulate Dr. Deshpande for sharing, the good work which they are doing in Pune. And I'm very, very positive and sure that our colleagues in IDA Pune chapter will collaborate with you and work towards, detecting these metabolic disorders early in age, especially reaching out to young adolescents, older adolescents, young adults. That's the future of this country. And intervene through a focused dietary and lifestyle intervention, and make sure that the damage is arrested early and we do not have an outburst of, diabetes and, NASH and liver cirrhosis and liver cancers, which we are seeing like rising, escalating, in the last couple of years. So it all boils down to basically the quality of eating and, your lifestyle. And again, I repeat, quality of eating needs to get focused to what is it that we really need to target. And one of the things which, again, nationally, FSSAI is also targeting is the HFSS foods, the high fat, salt, sugar foods. So there's a lot of effort to sensitize people, identify which are these HFSS foods, to drastically cut down on their intake, to drastically cut down on the intake of refined sugars, saturated fats, trans fats, high amount of salt, and also increase the level of physical activity. Today, according to me, as you write a prescription of medicine, we must write a prescription of exercise, whether it is aerobic and resistance put together, it has to be a part of our everyday life. So I think we are definitely, heading towards teamwork, coming together as professionals and working for a cause. The cause is that we want the Indian population to be healthy, not getting infested by, these diseases, wherein, when you look at the treatment, I think Indians, the affordability of medical treatment in India in itself is a question mark. So it is much more rationally, convincing that we come together to detect early, arrest the damage early, use our science to give, that empowerment to the people, to control on their diets, their lifestyle, to understand, one side is the negative, but the nutrition science today has developed so much that I can make a checklist of all the positive nutrients which are going to help improve the metabolic health and the inflammation levels in the body. And I think we did a small work using food as an intervention in the same randomized control trial. And within 3 months, we could see a decrease in glycosylated hemoglobin level, a decrease in LDL, a decrease in hyperinsulinemia, and a decrease in inflammatory markers. So I think nutrition science has a lot to offer. And if nutritionists join hands with the medical fraternity and we work as a team, I think time is not far off that we will be creating success stories in different parts of this country. So I am so delighted to be a part of this symposium, and I wish all, the speakers, a happy academic feast, academic deliberation. I know I can see the program. They're very, very good, speakers and good content to be shared with all the participants. And I always feel learning is best in a heterogeneous group. So it's a good blend of nutritionists and doctors attending this program. And that's where I think we are making a new and a very strong beginning. And I look forward to more such collaborations happening in the times to come. So all the best and good wishes and a God bless. Thank you very much again for giving me this opportunity.
Thank you, madam. So IMA is always there to help you and guide you regarding this collaboration. So no problem, madam. So IMA, as you know, our all doctors, we are all members, and non-members also know about the Indian Medical Association. It's a national association of all doctors. That is the only association of doctors. So at national level and at state level, as well as a local branch, we are from IMA Pune. So in Pune, we are having more than 5,500 IMA members. And this IMA Pune has been started since 1928. So just recently on 31st May, we have celebrated 94th Foundation Day of IMA Pune. So, as you know, there are all dedicated people and they are all there to help not only doctors in their all medical practice, so about the academic interest also, as well as in their practical practices also. So according, sometimes the people come to us with the medical legal problems. So IMA is there to help you. If there is any problem about fire problem in your hospital clinic, we are there. Just recently we had called Mr. Gilbile, he's a fire officer from PMC, and he gave and he guided our IMA members. So what I want to say, ki, along with medical, we are there to help you as and when required. So with these kind words, I request our President-elect Dr. Raju Varyani sir to give his welcome speech.
I only wish to add, madam, that
Yes.
consider nutritionists as a part of your team.
Yes, yes, madam. Sure, madam. Sure.
That's the message which
Yes,
I want
yes,
to
madam.
give.
Yes,
Yeah,
madam.
thank you.
Thank you.
Very good morning to all of you, respected dignitaries of IMA, IDA, online as well as offline. I welcome you all for this very important, nutritious CME, which will be very useful in day-to-day practice. IMA CGP is part of this CME, that is in association with IDA and Precise Clinic. As you know, IMA has different academic wings. Like one of the wing is IMA CGP, that is College of General Practitioners. We also have IMA HBI wing, that is Hospital Board of India, as well as IMA AMS, that is Academy of Medical Specialties. So various wings are there, CGP being one of them. IMA CGP wing will be very shortly conducting a FCGP course from 18th of June. It will be an online course for 4.5 months. After the completion of the course, there will be an examination in the month of November. Successful candidates will be awarded with Fellowship of College of General Practitioners. So I request all the IMA members who wish to do the course, you can enroll before 18th of June for FCGP course. It is a condensation of whole MBBS course in 4.5 months. There will be bedside clinics, as well as there will be oral practical examination apart from theory examination. So please enroll for FCGP. As far as today's CME is concerned, this is very important. The requirement of food is very important for our cell activity in the cell. It gives fuel to the cells of the body. If we reduce the dietary intake, there is slowdown in the metabolic process. So the nutrients, what we eat, determine the function in the cells and body. So nutrient form an important information for the body. They give an important information about the body, how the body behaves, because these are many chemical reactions taking place at the cell level, and slight changes in the minor enzymes, hormones make a lot of difference to the body. So these chemical reactions at the cellular level are very important. So today's CME will definitely help for the dietary management in various disorders and diseases. We must thank Dr. Kedar Patil for taking lot of efforts for this CME to take place. I now hand over to Deshpande madam. We will begin today's CME with I would like to call the chairpersons, Dr. Suhas Adekar. He is past president of IMA Pune. I request him to please come on the dais. Dr. Suhas Adekar is practicing family physician since last 32 years. He is practicing at Khadki Bazar. He is also the founder, member and secretary of IMA Trekking Club. He has more love for trekking as well as for his academic. He is trekking for last 25 years in Sahyadri and Himalaya. He has done more than 200 treks in Sahyadri as well as high altitude treks in Himalaya so far. He has done Everest base camp trek, which is 18,400 feet from Nepal, as well as Miley Pass trek. Actually, previously this trekking club was very active in IMA Pune. We will shortly revive that. Along with Dr. Suhas Adekar, we have Dr. Pawan Hanchanale as the other chairperson. I request Dr. Pawan Hanchanale to please come on the dais. Sir has been practicing hepatology and liver transplant physician more than 5 years in Pune. He is adept in managing patients with complete liver failure, liver critical care, jaundice, fatty liver, liver cancer. He is expert in managing liver-related and cadaveric liver transplants. He has been trained at Gleneagles Global Hospital, Chennai. I now hand over to Dr. Deshpande.
So let's start with the first session. It's my pleasure to introduce the first speaker, Dr. Ambika Nair. She's a registered dietitian, certified diabetic educator, corporate nutritionist, accreditation, certified NLP coach, and also having about 26 plus years of experience. She's a director at Sehat Nutrition, Wellness and Health Clinic, Aun. She's a consultant clinical nutritionist at Jupiter Hospital, co-convener, Indian Dietetic Association, Pune chapter, RD board representative, Indian Dietetic Association. She's the HOD of Nutrition, DES College of Nursing. She's also responsible for planning the board of syllabus for MSc Dietetics, Symbiosis Skills University. She's working at various levels as a corporate nutritionist. She's also worked at various organizations like Prana Healthcare as a chief nutrition officer. She has been a panel advisory board for several associations and organizations, and she's a certified NLP coach, RE and CBT therapist from New York. It's a pleasure to welcome you, madam.
A very good morning to all of you. It's a Sunday morning and happy to see many of you all here. So let me first thank IMA Pune, Indian Dietetic Association Pune chapter, IMA CGP Pune, Precise Clinic for giving me this opportunity to present before you the the hidden iceberg, which Dr. Jagmeet Madan had mentioned. So I'm going to talk about NAFLD, the hidden iceberg. So basically, the concern about this disease is it comes under the category of metabolic syndrome. So let us understand, before we get into the nutritional management of NAFLD, I would like to give a few slides on the diagnosis, the pathophysiology, the nutrients which are responsible for NAFLD or the progression of NAFLD. So in simple terminologies, NAFLD is a condition in which excess fat is stored in the liver. This buildup of fat is not caused by heavy alcohol use. When heavy alcohol use causes fat to build up in the liver, this condition is called as an alcoholic liver disease. So non-alcoholic fatty liver disease is what we're going to talk about. Now, when we talk about NAFLD, there are two types of NAFLD. It's a simple fatty liver and NASH, which is non-alcoholic steatohepatitis. So I'm just giving you the basics beginning, and then we'll get into the micronutrients and the nutrients responsible for NAFLD. Now, simple fatty liver, the term is also called as non-alcoholic fatty liver, NAFL. It's a form of NAFLD in which you have fat in your liver, but little or no inflammation or liver cell damage is seen. Simple fatty liver typically does not progress to cause liver damage or complications. Whereas if you see NASH, the difference between the two is there is inflammation associated in the hepatocytes. So, and there is liver cell damage, and it can also cause fibrosis or scarring of the liver. So NASH may also lead to cirrhosis or liver cancer. Now, this is a typical definition, which is more, concrete about all the three conditions. So what it says is, if there is steatosis, that is fat accumulation more than 5% of hepatocyte in the hepatocytes, that is called as NAFLD. Similarly, there is an exclusion criteria. So exclusion of secondary causes and alcohol, so the criteria for daily alcohol consumption, like less than or 30 grams for men and 20 grams for women, excluding that criteria, we call it as NAFLD. Now, as I told earlier, NAFLD has got two parts, which is NAFL and NASH. NASH, as per the fibrosis stage of fibrosis, if it is early or fibrotic or cirrhotic, and it can convert to hepatocell carcinoma. So these are the definitions which are given by EASL. Now, what is the prevalence of NAFLD? Prevalence, it's really alarming. As Dr. Jagmeet Madan ma'am already mentioned, in studies conducted in Asian population, it says that at least 30% are affected with NAFLD. Now, if you see the epidemiological challenge behind it, this is a very interesting figure, which says that in 1974, the mean BMI of the population of 195 million was, around 30, more than 30 was BMI, more than 30 was 105 million. Whereas in 2014, it is 641 million people have BMI more than 30. So this is number one alarming, thing for us as medical practitioners. Apart from that, 20 to 30% of the population in Europe suffer from NAFLD, 3% suffer from NASH, and 0.2 to 0.5 progress to hepatocell carcinoma. In the Asian population, in Asian Indians, what is seen is it is like up to 1/3 of the urban population is affected by the disease. So it's a silent killer. So till the symptoms are seen, nothing is, basically the symptoms are very hidden. So we are not able to identify whether the person has NAFLD unless and until there is a complication which is seen in the USG or in the liver enzymes, if there are increase in the liver enzymes or further other parameters. So in Asian Indians, NAFLD is precipitated by multiple factors. The common factors are excess of abdominal fat, that is subcutaneous abdominal fat, that is intra-abdominal fat, the lifestyle factors, and it's also correlated with insulin resistance, metabolic syndrome, dysglycemia, and the background of genetic predisposition. So there are a varied amount of genes which have been investigated in Asian Indians, like PNPLA3 is one common one, which says that you're prone to NAFLD. Similarly, apart from the diabetes and other complications, the CVD is also risk, which can be subclinical inflammation and surrogate markers of atherosclerosis, also is one risk criteria. So there has been a prediction equation for, it's called as an Indian Fatty Liver Index, which includes simple measures which has been developed by Asian Indians. Now, it's a clinical challenge. Non-alcoholic fatty liver disease, as it is talked a lot upon nowadays, related to metabolic syndrome. The older the age, it's seen more. Nowadays, in young Indians, young Asians, it's seen much, much higher because of the lifestyle management. Higher body mass index is seen. Many comorbidities like diabetes, kidney, cardiovascular disorders are seen in this condition. Substantial proportion unaware of their liver condition. So most of us are not even aware that the liver is already, maybe 50% damaged. Higher rate of malignancies are also seen in this condition. The causes of NAFLD, so quickly let me go through. Overweight, that is obesity, is one major cause. The second is insulin resistance, metabolic syndrome. So metabolic syndrome, what we, according to the term, larger the waist size, larger the waist circumference, more of visceral fat, higher levels of triglycerides in the blood, higher levels of LDL, IDL, and low levels of HDL, high blood pressure. All these are comorbidities which are seen in NAFLD, and most of the patients do have type 2 diabetes too. So research also suggests that certain genes, as I mentioned earlier, are also responsible for NAFLD. If you can see the close loop, the loop of NAFLD, non-alcoholic fatty liver disease, it's a metabolic syndrome circuit. So insulin resistance, high blood pressure leads to, obesity leads to this. It's a vice versa, basically. So, and abnormal lipid levels, abnormal cholesterol levels, again, causes the condition. Now, the other complications of NAFLD, apart from being the reason or the etiology of NAFLD can also lead to other complications such as colorectal cancers, hypothyroidism, osteoporosis, PCOS, sleep apnea, and chronic kidney disease. The diagnosis of NASH, I think this is the medical fraternity takes in charge of this. What is the right diagnosis for NASH? Generally, the medical history, in short, would include metabolic syndrome identification, lifestyle history, type 2 diabetes, if it is, what is the type of diabetes. In physical examination, the most important thing is the BMI. Apart from the BMI, as we all know, BMI is not the right anthropometric criteria. The body composition analysis is what is required, which tells us the segmental fat, the visceral fat, the intra-abdominal fat, etc. So we need to consider the BCA. And for liver cirrhosis, the physical examination is done, and insulin resistance. Other imaging tests like all the blood parameters of the liver function test, USG, CT, MRI, liver biopsy, all these are the diagnosis tests which are done. There are certain slides which I have just mentioned about the staging of fatty liver disease. So liver biopsy is essential for the diagnosis of NASH. NASH is a further complicated state of NAFLD. So NAFL, that is non-alcoholic fatty liver, the difference between the diagnosis of NAFL and NASH is that NAFL encompasses steatosis alone, but one or just one of lobular or portal inflammation or ballooning is seen, whereas in NASH, it requires steatosis and lobular and portal inflammation and ballooning is seen. Either of them is the criteria. Here, all the parameters are seen, and there are particular scores. NAS scoring indicates severity in this. So if you can see the slide, you can understand how the normal liver looks, and NAFLD and fibrosis, the liver with fibrosis, and NASH. A potential algorithm for risk assessment in non-alcoholic fatty liver disease. So what it says is the hepatis steatosis on imaging, it can be categorized into 3 categories, which is low risk profile, immediate risk profile, or high risk profile. So based on the fibroscans, based on the BMI, based on other metabolic syndrome criteria, it is staged. Now, apart from this, EASL guidelines 2016, which recommends liver biopsy for NASH or fibrosis if it is suspected. Now, let's go to the pathophysiology and treatment options in NAFLD. Now, there is something called as a 2-hit hypothesis and multiple hit hypothesis. So what it says, 2 hits hypothesis says that the first hit is fatty liver, which is fat accumulation in the liver, added on to insulin resistance. The second insult to the liver are the further insults which we already discussed. And apart from these, the multiple hit hypothesis, it says there are endotoxins or there are adipokines which are secreted, there is gut microbiota dysbiosis, or if there is any inflammations or epigenetics also can add on to it. So the hypothesis says more the pathophysiology, more the condition is going to be more severe. Now, role of nutrients. Now let's get into the role of nutrients in the pathogenesis of NAFLD. I think all of us are aware of the fact that processed foods, we always tell our patients, do not consume processed foods, packaged foods. The reason is because processed foods do contain good amount of trans fats. That's number 1. Number 2 is fructose. Fructose, high fructose corn syrup, cholesterol, etc. So these can add on to the complication of NAFLD. I'm going to give you the exact biochemical pathway behind all this. Why fructose? What is the role of fructose in the pathogenesis of NAFLD? Now, if you see the nutritional factors, the two columns which say that the factors which are going to precipitate NAFLD are increased energy when you consume more calories, when you have more of dietary sugars, or when you take more of saturated fatty acids, or when you take more of animal proteins. And by animal proteins, more of red meat, nitrites, which contain nitrites and nitrates, which in turn increase your visceral fat and therefore increasing the chances of NASH too. So increased amount of salt in the diet and low amount of fiber in the diet can lead to this complication. So apart from these, we have already talked about the various lifestyle factors which have actually contributed to NAFLD. Now, what is the best kind of diet which is sort of suited for NAFLD? The common diet, as dietitians, we all know there's something called as Mediterranean diet and DASH diet. Now, DASH diet is nothing but dietary approaches to stop hypertension. And Mediterranean diet is a wholesome diet containing good amount of fiber, high amount of like around 30 to 40% of fruits and 60 to 70% of vegetables, and little bit of lesser and simple carbohydrates, more of complex carbohydrates, and good quality proteins and good quality fats. So that's a simple gist of Mediterranean diet. And Mediterranean diet contains good amount of polyphenols. So polyphenols, by polyphenols, I mean the dark red, yellow, orange colored fruits, vegetables, etc., which contain good amount of polyphenols, which can prevent the progression of NAFLD to NASH. Now, role of fructose, I guess this slide is visible, right? So what it says is a diet when you're taking very high fructose. So exactly the metabolism of fructose. So fructose metabolism, it leads to the depletion of ATP. So the ATP is converted to ADP, and then in the process, uric acid is produced, which both trigger the reactive oxygen species, that is ROS, which is generated in the liver. More and more of ROS in the liver is going to damage the liver. So high fructose consumption can also cause gut dysbiosis, if you can see in the picture, which influences the liver oxidative status. Apart from this, dietary cholesterol. So what it does is it destroys the mitochondrial tissues, mitochondrial dysfunction, and further mitochondrial ROS production. So wherever there is more of ROS production, there is more of complication in NAFLD. In contrast, there are several micronutrients like vitamins and multi minerals, etc. Like examples are carotenoids. Vitamin E plays a very, very good role in decreasing the adipokines, and some amino acids like glycine and serine. I think we all know the GSH composition is glycine and serine. So these amino acids are very helpful in, and they have antioxidant properties, and they are beneficial in NAFLD. Now, as I was talking about fructose, excessive fructose is also associated with inflammation and cellular stress, dysbiosis, and hepatic steatosis. Fructose strongly activates your de novo lipogenesis. So more and more of lipids are formed when you're going to take more of fructose. Now, fructose is also present in fruits. That is why we say, like, don't take too much of fruits, because too much of fruits can also increase your triglycerides. And therefore, again, it is going to increase your, gut dysfunction too. Similarly, other pathways, I'm not getting too much into the biochemical pathways of this, but in short, what it does is it causes more of hepatic insulin resistance and inflammation. Apart from these, fructose also increases the peripheral insulin resistance and also increases the cytokines and lipid oxidations. Now, what about the role of lipids and cholesterol? As such, we all have heard a lot about cholesterol. So the lipids and cholesterol, they cause hepatotoxicity at a higher amount. Basically, what they do is, again, they alter the mitochondrial calcium homeostasis. They increase the ROS production, and they again lead to lipotoxicity, and therefore even activates the endoplasmic reticulum stress, and therefore leading to more of peroxides formation. So more and more of peroxides formation is going to damage the liver. So it's a simple philosophy that once the inflammation increases, more and more of free radicals are formed, reactive oxygen species are formed, therefore destroying the liver. Now let's talk about animal protein. Now animal protein, we are aware of like lean meats and red meats. Now lean meat, by lean meat, I mentioned like it's about your chicken, fish, egg whites, etc. are lean meat. Whereas red meat, pork, beef, and all these mutton and everything, they contain high amount of nitrites and nitrates. And the process of, so there are some very good studies. I would like to mention one of a very, very good study, which was quoted in 2018. So what it says is, a diet which is very high in animal protein increases the risk for fatty liver. And among people who are overweight, it's published in Gut. And researchers, what they did is compared the intake of fiber, protein, and other macronutrients with liver disease incidence rates via ultrasounds in 3,882 participants from the Rotterdam study. So what it showed is there was a 36% higher risk for fatty liver disease for those who consume the most animal protein compared with those who consumed vegetable sources of protein. So for a patient who has got NAFLD, it's always advisable to restrict the red meat or animal protein to a larger extent, but the lean meat can be included in a smaller amount with a good quality proteins. The suspected mechanisms behind the increased risk is nitrates, nitrites, and heme iron, which influences the insulin resistance. This is also one more study, which is called as a FLEO study. What it says is it's about the fatty liver in obese individuals. So again, the FLEO study says about the role of red meat, the role of processed meat, fish consumption. Now, fish consumption was inversely related, meaning more you consume fish, it's much better for your concentration. It helps to actually lower the concentration of ferritin, whereas when you consume red meat, the concentration of ferritin, which is going to increase. So the better alternative in animal proteins, I would suggest, is fish. Now, microbiota, fiber, and NAFLD. Is there a association with fiber? Definitely prebiotics. The dietary fibers play as a role as prebiotics. They help in formation of probiotics in our intestine. So the gut microbiota helps generally. If there is a dysbiosis, there is more of fatty liver complications seen. So by the gut microbiota, the best bacteria, which is generally helps in regressing the disease, is bifidobacteria, which helps in reducing the complications of NAFLD. Now, the symptoms, as I said, you may not develop any symptoms, but if there are any cirrhotic symptoms, it's generally seen in the imaging. Now, the progression of fatty liver and the regression. So diet can be a contributor or an enhancer. Similarly, diet can help in reversing the disease. So as you see, the normal liver progresses to NAFLD and then to NASH fibrosis, to cirrhosis, and hepatocellular carcinoma. So there are interesting studies which say that, coffee, exercise, Mediterranean diet, vegetables, etc., help in alleviating the symptoms, whereas other contributing factors, which we already discussed, helps in progressing the disease. Now, this is a simple pyramid, which is NAFLD lifestyle treatment pyramid. So what it says is we need to have aerobic or resistance activity. It's required. So physical activity, the role of physical activity is it reduces the liver fat, but definitely there is not much of evidence that exercise can help prevent NASH or fibrosis. The second is dietary composition. So modification of the diet with or without weight loss. So I think most doctors, Dr. Pawan, and we work together in Jupiter, we see a lot of NAFLD patients where weight loss has tremendously helped patients recover from the condition. So a 5% weight loss definitely helps. So what the guideline says, up to 5 to 10% weight loss is really effective. Apart from that, like steatosis, is very reversible, or the fat accumulation with some as less than 5% weight loss. NASH up to 7% and fibrosis up to 10%. The surgical treatment, interestingly, bariatric surgery is an option in patients unresponsive to lifestyle changes and pharmacotherapy. This is also one of the studies which was published in EASL. So these once there is an indication of clear-cut NASH or cirrhosis, and it helps to reduce, bariatric surgeries definitely help to reduce complications and weight management. So this is one of the interesting approach. Other than this, what I would just sum it up is like a comprehensive lifestyle approach. The comprehensive lifestyle approach says energy restriction. Now, how much of calorie you need to restrict? 500 to 1000 kilocalories per day. 7 to 10% weight loss should be the target. Long-term maintenance approach. Fructose containing drinks, especially, the aerated drinks, your Pepsis, Mirandas, all the aerated drinks to be completely avoided. Alcohol intake strictly below 30 grams for men and 20 grams for women. Coffee consumption, there is no liver related limitations. People are so scared to consume coffee, it causes hyperacidity. And so there's not much of limitation or not much of studies shown, though coffee is not going to be a useful thing for liver. So we need to take it with a pinch of salt. Now, macronutrient composition, you need to take a low to moderate fat, moderate to high carbohydrate. Low carbohydrate ketogenic diets are also effective, though not many studies are seen. Now, physical activity, about 150 to 200 minutes a week is what is recommended in 3 to 5 sessions. This is, I don't know whether it's that clear, but still it's just an overall picture about everything, like how the genetics and environment contribute, where the genetics, especially the gene, PNPLA3 gene, which has been identified. So nutrigenomic diet definitely plays a role here. If you identify that there is a particular gene which is going to cause you the NAFLD or NASH issue, definitely you can give that particular nutrigenomic diet. Dietary saturated fat, fructose, and sedentary lifestyle. The clinical features we already saw, the dyslipidemia, etc. The disease mechanism, this is the doctors who can handle the disease mechanism, the lipotoxicity, the microbiome inflammation and innate immunity, how to strengthen them. And the current treatment modality is lipid reduction through weight loss, improve NASH through vitamin E. I'm just going to give you 2-3 more slides about the role of 2-3 important nutrients like vitamin E and role of fiber, etc. So fibrosis regression is seen with 10% weight loss. So how can our diet improve? So focus on portion sizes. Portion control is very important when you're going to talk to your patient. So limiting the portion control, eating a healthy diet, balanced nutrition with weight reduction. So doctors recommend weight loss to treat non-alcoholic fatty liver disease. Similarly, if one is overweight or obese, losing weight by making healthy food choices, as I said, portion control. So, and losing at least minimum of 3 to 5% of body weight can reduce fat. Generally over a period of 1 year, more than at least there should be a 7% weight loss. That should be the target. But rapid weight loss is not recommended, like crash dieting or liquid diets or very low calorie diets are not recommended because the patient is already into micronutrient deficiency. Now, the Fatty Liver Foundation recommends these things like the role of omega-9. Now, omega-9 is in vogue. We have heard about omega-3 and omega-6. Now, omega-9 is oleic acid. Oleic acid has got a superb role to reduce the symptoms of NAFLD. So what is the source of omega-9? Extra virgin olive oil, etc. contain omega-9. Low saturated fats, trans fats, less than 7%, etc. Protein up to 20% of the calories, and whole grains. Consume more of whole grains, and simple carbs such as sugars and refined sugars should be minimized. And the salt intake is about the goal for salt intake as per the WHO recommendation of around 5 grams, which is around 1 teaspoon a day, and processed meat to be completely reduced. Now, the dietary pattern, Western diet, the red color says that Western diet is a cause or the etiology of NAFLD. All of us, like, when we're partying or on a weekend, we just go and, pick up some KFCs or burgers and, all these fried food, etc. I'm not saying we are not supposed to have, but we can, but once in a while, because that, if it's going to be prolonged, the youngsters, if you see staying in hostels, they're only consuming fast foods. So they have a high amount of risk of NAFLD, and the symptoms are also unnoticed. So as I mentioned, the Mediterranean diet, which contain good amount of PUFA and low saturated fatty acids, and DASH, that is dietary approaches to stop hypertension, is definitely recommended. This is a picture of the Mediterranean diet. This is what we dietitians, we give for every patient in our diet chart. We explain what are other, the base of the diet, the base of the pyramid has to be more, and the top of the pyramid, which is red meat, white rice, white butter, all these should be minimal. So the contributing factors is fructose and trans fats. The regressing factors are the other vitamins, C, E, and D, etc. The micronutrients. So basically, as I mentioned, vitamin E. has a very good role. Up to 400 to 800 units of international units of vitamin E can be supplemented, because they are anti-inflammatory. They help to increase the M2 anti-inflammatory macrophages in the liver, whereas because astaxanthin and cryptoxanthin, which are present in fruits and vegetables. Limit intake of fats, we've already mentioned. What kind of fats? Monounsaturated fats, which is more present in canola, olive oil, peanuts, etc. And even polyunsaturated fat, do not consume more, because omega-6, that is in corn oil, soybean oil, palm oil, all these contain omega-6. So even those need to be in a minimal quantity. Similarly, omega-3, which is fish liver oil, capsules, etc. These can be, or fish itself is a very good source, which can help again in reducing the complications. Omega-3 for vegetarian sources are walnuts and flax seeds, etc. So trans fats, anything which is present in a packet, avoid. You can tell this to the patient that stop taking any packaged foods. So that will suffice the whole thing. So there are various diets which have been proved that, Atkins, ketogenic, so which is better. So the fatty liver friendly diet says that the primary lipid should be omega-9, which is oleic acid. It's like a treatment modality, and the percentage of lipids are also as per your energy, which we decided, not more than 20 grams of fat in a day. Other guidelines: eat low glycemic index foods, avoid foods and drinks that contain large amount of simple sugars, avoid heavy alcohol use, definitely. And experts have mentioned that heavy alcohol is more than 4 drinks per day or more than 14 drinks per week. That is categorized as heavy alcohol. So these are some practical tips. Last one slide, where this is what we can just give it as a take-home message to our patients. We can just say, like, eliminate all alcohol, eliminate saturated fats, eliminate all non-skimmed dairy products. So basically low-fat skimmed milk. So there is a difference between skimmed milk and cow's milk. Cow's milk has 2.53% fat. Skim milk has 0.2% fat. So we need to reach out to skim milk. Similarly, eliminate all high fructose corn syrup, and sodium goal should be around 1,500 milligrams. Eliminate all dietary sugar for complicated cases. Make sure that any medications that you're taking do not harm your liver. Be aware that eating out is tough, as very little of it is good for you. So take 1 tablespoon of refined fish or salmon oil, which is extremely good for health. And do not buy prepared foods, and look for fiber, like fiber-based foods, and eat skinless chicken or lean meat. So these things, like 3 to 4 cups of, people taking 3 to 4 cups of filter coffee a day. This is what is mentioned in NAFLD Foundation, but I'm not sure how many research papers are there about coffee, right? So what I would like to conclude is, this is the scenario now. So we can take the help of artificial intelligence and prepare design more personalized diets for NAFLD, considering all these parameters into control. Check the gut microbiome, check the genetic test, do your genetic panel, and physiological parameters, which we already mentioned. Check the food history, the dietary history, anthropometrics like body composition analysis, waist circumference, lifestyle, and environment. So all put together, I think once we do the right diagnosis, we can put it all in artificial intelligence, create a much better, personalized diet plan, and give reminders to patient not to consume. So these things can be possible in this age. So thank you all. Thank you for patient listening, and meet a qualified nutritionist or a registered dietitian for personalized nutrition advice. That's anytime better than taking any information from Google or the internet. Thank you so much.
Thank you, Mrs. Nair, for this wonderful session. I think it's Sunday morning. We are all missing Mr. and coming here to listen your NAFLD lecture. That's a wonderful talk indeed. So I agree with you completely. Whatever slides you have, actually you've shown all medical slides rather than the nutritional slides. So this is as good as a lecture given by any hepatologist. Thank you for that. For basic, see, there's a lot of fatty liver which is going up. If you ask me, like COVID, we are actually in the pandemic of a fatty liver. You know that the maximum population in the world with obesity and diabetes is in India. Okay, that is one. So we Asians are gifted with certain genes. Already, Madam has said that PNPLA3. That's a gene which is actually given. This is more common in Asians, and which is causing more of fatty liver predisposition as compared to the diet. We know that obesity, yes, obesity is related to the fatty liver, but as structured. So if you take 100 patients in India, out of which 80 to 90 patients will be obese, which leading to fatty liver. But 10 to 15 patients are called as lean, and they are called as lean NASH or lean fatty livers. And that these are the patients who are actually predisposed to have a more liver problem as compared to other people also. And this is all genetic driven. So these are the patients we have to screen them. So all fatty livers, because if you see ultrasound scans which are coming to you in a day-to-day practice, a lot of people are having ultrasound showing a fatty liver, and we most of the times fatty liver, this is how what is the approach of a lot of people of us. So we have to screen these patients with a fatty liver. Fatty liver can be divided into two groups. One is isolated fatty liver, and secondly, fatty liver converting into liver disease. Isolated fatty liver. So if you take 100 patients, 80% of the patients can be isolated fatty liver throughout their life. That is one. 20% of this fatty liver will get converted into liver disease called as NASH or liver cirrhosis. And what is the time period between them is around 15 years is the time what is required from converting a fatty liver into NASH or NASH into liver cirrhosis further. So this 15 years of a period, around 10% of the fatty liver patients over 15 years period will get converted into liver disease. This is a general statistics which is given in the research papers. This is what we need to remember. Which fatty liver are dangerous? First, people having a metabolic syndromes, they're having insulin resistance, they have diabetes, or any person who has a family history of a liver disease or liver cirrhosis are the people who are at risk of a liver disease. Initially, we used to call them as cryptogenic cirrhosis, म्हणजे cause not found. ज्यांचा etiology माहिती नसते आपल्याला liver disease ची, those cryptogenic were actually a fatty livers converting into liver disease and causing liver cirrhosis. So this is one. Any patient with a fatty liver with risk factors and abnormal LFTs, that is what is more important. Liver function test getting abnormal, SGOT, SGPT getting deranged is a problem, and these are the patients which we categorize into NASH. NASH can cause NASH of liver. So livers are NASH karu shakta NASH. So make sure that all fatty livers, you should do liver function test. So SGOT, SGPT deranged, we need to investigate them. We have to find out why this is abnormal. Even 1.5 time rise, normal cutoff is 40, SGOT, SGPT, even 50, 60 is definitely some processes going on in the background. We need to investigate them. So how to investigate? What we do is general screening. We do metabolic workup. We do lipid profile. We do ultrasound scans. So after ultrasound scan, what we newer investigations, what we use is fibroscans. A fibroscan, these are the tests where we actually can categorize how much fat is there in the liver and is it affecting the liver? Is it causing liver fibrosis? Liver fibrosis means regular inflammation causing liver fibrosis, and fibrosis will lead to liver cirrhosis. The fibrosis is diagnosed by either liver elastography or by liver biopsies. Doing biopsies is really cumbersome because patients will not be ready or it is invasive procedures. So elastography is what we use nowadays more than liver biopsies. Even MRI elastography are the few tests where we can actually diagnose liver fibrosis or liver getting damaged because of the fatty liver and causing a problem. And intervention management, I think you have already gone through in detail. Just wanted to ask you, what advice would you give on use of oil to the general public? So how much oil to be used? Is there a quality and quantity matters? So
Yes.
this is a question, general.
Yes, doctor. Definitely oil in the general guidelines, we always say which is the right oil. Like there is no particular one single oil that we recommend. So the concept now is blended oils. So we have a combination of omega-3, omega-9, omega-6. So meaning, so patients won't understand what is this, right? So we give it in the layman form. So what is the amount of like cook maybe in rice bran oil, which has got a lesser amount of, the omega-6 is present, but it doesn't cause the pro-inflammatory marker. So basically rice bran or soya bean or any kind of oil is what is recommended for cooking. And what I generally recommend is for the liver, medium chain triglycerides, that is MCTs are very good. Like coconut oil, nowadays cold pressed virgin coconut oil is available. So many of the liver patients, when they consume, or I know the taste is different for different population, but by just taking like a medication of 1 tablespoon of MCT oil, it really helps. We have seen a drastic change because it doesn't require bile for absorption. We know that. So MCT is one is recommended up to 5 ml 3 times. Like, we can recommend that for liver patients. And for cooking, we can use olive oil, like pomace olive oil is used, which is omega-9, and extra virgin olive oil, I always tell for salad. This is a practical guideline which I give my patients. So how much of oil, when we say around 30 grams, like visible and invisible fat matters. Now, visible fat, you limit to only 30 grams, not more than that. Invisible fat is what is present in your coconuts or in your almonds and nuts. Any which ways there is some amount of invisible fat. So the total fat has to be divided as visible and invisible fat. And the ratio of omega-3 and omega-6 also has to be considered. Like 1 capsule of, fish liver oil capsules definitely help, like 1200 milligram with EPA and DHA right proportion. We need to be recommending that. And vitamin E also. I mean, I just also had a question, doctor. Do you also prescribe vitamin E to patients?
In fact, I was about to ask you the same thing. Thanks for a very good lecture. When do we start this vitamin E and to which patients?
Yes. So vitamin E, I generally, I think
this.
Dr. Pawan can answer that. And then I will
see many
add on
patients
to
with
that.
this reports coming with fatty liver or early changes of fatty liver. So when do you really start vitamin E for them? And oleic acid, as you mentioned, apart from the olive oil, where else would you find?
Omega-9.
Yeah, omega-9.
Yeah, omega-9 is oleic acid. Oleic acid is present in, canola. There is a particular oil called canola. So that contains oleic acid, but these are not easily available in India. Now olive oil has come in vogue. And there are like 100 types of olive oil. People are confused what to buy from. Very expensive. Extra virgin olive oil. So I tell my patients, like you buy a 250 ml, meaning in fact, literally in this terms, I tell them, just buy a 250 ml of your extra virgin olive oil. Use only 5 ml, not even 2.5 to 5 ml every day. It's enough. The amount that is recommended is that much of oleic acid, and that should last for 1 month. So that 250 ml, which is around $500, 250 ml, that can last for a month. It sounds little better. And that is enough. Like how we say 1,200 milligrams of, fish liver oil, it's enough. So that is what is recommended. And vitamin E, I think Sir can say.
So basic treatment of fatty liver revolves all around nutritional restriction, weight loss, and diet. Rest, everything comes secondary. So whatever we do, we have to tell them 10% of weight loss, 10% of body fat loss is what is required. So if the patient has a NASH, 10% weight loss, only reversal of fatty liver, if you really need 5% of weight loss is enough. But you tell them 10%, it will reach around 5-6%.
Right.
So that is one. Nutritionally, low carbohydrate diet and low fat diet is what is required. So we still eat a lot of carbohydrates. So even if a lot of studies are showing high carbohydrate diet and low fat is good, but because most of the studies are done in Western population. In Indian, if you see, actual maximum what we eat is carbohydrates. So we eat
carbs.
rice, we eat chapatis, and this much of sabzi is what we eat. So we have to reverse the proportion of all these things if you really need to caloric restrictions. That is another. Vitamin E has a role in patients who have a NASH. Definitely, that's a class 1 recommendation. So 800 of international unit of vitamin E is suggested for around 2 years. It should not be given in patient with diabetics. So non-diabetic patient is what we advise them. Other medications have come up. There's still trials which are going on. Lean trial or NASH trial, which is running maybe now in step 3 of studies. So saroglitazole is one of the medications what we use commonly in the patient with proven NASH. That is biopsy proven NASH. Nowadays, a lot of hype about obeticholic acid, which is going on. So these are the few newer medications which have to be used at the end of the spectrum in patient with fatty liver disease, NASH, actually. So this is the therapy. Yes. So cod liver oil is ultimately, basically
Omega.
all revolves around omega. So what, if you ask me, what we need is restriction of all sorts of oils rather than giving in addition. If you reduce the quantity, quality doesn't matter at the end, because if your quantity goes up out of the roof, whatever we eat, even we use olive oil, you use coconut oil, everything is going to cause a fatty liver, because excess of nutrition, this is a God gift to us. Excess of nutrition, whatever it is going to get stored as fat in the liver. So we have to cut down on the nutrition, go on a hypocaloric diet. This will start reversing your fatty livers. And you have to have a regular follow-ups, because NASH patients are predisposed to liver cirrhosis first, and even liver cancers without development of liver cirrhosis. And we are seeing those. If you ask me, next 20, 30 years, we are going to touch or more cross alcoholic liver disease with NASH. So this is next 20, 30 years projection, what I feel is going to be. So we have to control fatty livers. So fat comes because we are inert, but fat is not inert. This is what I want to say. Just keep this in mind.
And the last fat that leaves our body is the visceral fat, the abdominal fat. So how much of our exercises we do, I think the stubborn fat is in the intra-abdominal fat. And about the vitamin E, we can also give vitamin E containing foods. Like walnuts and almonds, because these are anyways definitely recommended. So one study says that around 2 handfuls, that is 2 fistfuls of almonds given for 90 days has brought down the condition drastically. So these were like interesting, but 2 fistful is really good amount of money of vitamin E almonds, and every day for 90 days. So sometimes, little bit of vitamin E containing foods can be recommended here.
Vitamin E is fat soluble, should not be given continuously. There should be a break between the two treatments. There can be toxicity of vitamin E.
Ambika, I just like to come in here.
Yes, ma'am.
A very nice talk, excellent presentation, and I think some very valid points made. I just want to make a suggestion here that when it comes to visible fat, I think it is always good to tell people not to go beyond 2 level tablespoon per person per day, which is close to about 8 ml is 1 tablespoon, so about 16 to 20 ml. I would shudder to say even 30 ml visible fat, because the more we make people conscious and say that your total oil intake per person per month should not go beyond 500 ml. I think these are very important messages which need to be given to people, and there should be a lot of emphasis on good quality fat coming from invisible sources. And like you did mention about nuts, and nuts are definitely giving good quality fat, your oleic acid, your vitamin E, your important minerals, fiber, protein. So I think that's a nutrient density also coming along with your caloric intake. And somewhere I feel in today's time, people spend a lot of money in buying junk foods, and especially the young adults, which are the most vulnerable group heading towards NAFLD. So they have to weigh the pros and cons of what goes in as a snack, whether it is 2 handfuls of nuts, or other 2 pizzas, or 1 pizza and 1 burger and 1 donut and 1 Frankie. So I think if you do the cost analysis, it's pretty much very clear what we want to pick and choose. But yes, I completely agree with what the chairperson said. One is that we have to quantify the oil. That's very, very important. 2, we have to cut down on the total carbs in our diet. That's very, very important. Again, we've been talking about the Indian plate and, the 4 portions, and we say that it's only one portion which should be your rice or your roti. The others, the half of your plate should be fiber, your vegetables and salads, and one should be definitely protein. And for sure, of course, lifestyle changes. Like I told, that exercise has to be a prescription today. We cannot get away, without doing that. So thank you so much. I think it was very, very interesting to have this conversation.
So much,
Thank you,
ma'am.
you know,
Since we
yeah.
are running short of time,
Yeah.
we shall proceed to the next interesting
Yeah,
presentation.
thank you. Thank you once again.
So can we please discuss this?
Can we please have this
Discussion later
because
on?
we are running short of time.
Yes.
Yeah, we are already about 20 minutes late. Yeah, we can have it during that. Thank you so much, ma'am. Over
Thank you
to
so much. Thank you very much.
Over to you, yeah.
I think the session was very interesting and everybody has got a lot of questions, so we can take it ahead. I would now like Dr. Alekar to continue to chair for the next session. Can I please have Dr. Meenakshi come on stage to felicitate Dr. Pawan? Okay, okay. Just a felicitation of him. And after the next session, it will be yours. Thank you, madam. Thank you, sir. Speakers to restrict your time. Yes, sure. Now, can I have Dr. Raju Varyani come over on stage to felicitate Mrs. Ambika Nair? Thank you so much, ma'am. Dr. Raju, would you please introduce the next chairperson?
For the next talk, I invite renowned nephrologist, Dr. Sunil Zavde, to please come on the dais. Dr. Sunil Zavde has done MD DM nephrology from KEM Mumbai. He is consultant nephrologist at Yashwant Kidney Care, Pune Hospital, Sanjeevan Hospital, Jahangir Hospital, Inamdar Hospital. He is associate professor at Bharti Hospital and Research Center. He is in charge of dialysis center at Pushpa Devi Dugad Charitable Dialysis Center and Sanjeevan Hospital. He has passed undergraduation with distinction in 5 subjects, and he has came 4th in MD Medicine Pune. He has presented 5 research papers and 10 publications. His special interest is in continuous ambulatory peritoneal dialysis and renal transplant. Over.
It's my pleasure to introduce the next speaker. I think she's been a mentor to many of us present here. Dr. Geeta, she's a doctorate in food science and nutrition. She's a gold medalist in Master's Food Science and Nutrition. She's a registered dietitian and a clinical nutritionist. She is the director and founder of Geeta NutriHeal Consultancy. She's a chief nutrigenomic counselor, Gene Support. She's an executive member, Indian Dietetic Association for a very long time, past chapter president. She's a faculty CCIH. She's a guest faculty at Symbiosis Institute of Health Science and bariatric course coordinator. Ma'am, a pleasure to have you over. Thank you, Avanti, for the kind introduction. Respected chairpersons, I am a Pune chapter, IDA Pune chapter. Thank you so much for inviting me and asking me to deliver a topic which is related to metabolic syndrome. It's a 25-minute talk. may not cover everything. We have our chairperson, eminent nephrologist here, and he knows diet cannot be a 20 minutes game in a kidney diseases. I would like to set a stage because the previous talk had a lot of thought process. You wanted to know which oil, why trans fats. So many questions when it comes to diet. And I feel diet is a very negative term when we speak. Nourish is a very positive term. Actually, diet means way of life in Greek, and that's how this term was originated. And then the medical terminology started telling us medical nutrition therapy. And we started looking food as deprivation or don'ts. And the dietitians do spend a lot of time in talking to patient about not to eat, especially when it comes to therapeutic diet. Somewhere that must be leaving patients confused. Patient goes back to the doctor and says, "Khaitsa tari kai? Kai khaitsa ri sangu naka? Kai khaitsa sanga?" This is a common way a patient starts telling a doctor as well as a dietitian. Because in today's era, food information is not a deprived information. What we are here for as an expert is to personalize. As I started practicing from past 25, 30 years, thought process started changing about nutrition. We have to start looking nutrition in an Indian scenario, in an integrated approach, is what I started feeling. Body cannot be 1 + 1, 2. I eat a chapati of 1 with a 150 calorie. I do not know whether my body will consume all 150 calories. Similarly, I think the food which I eat has a response to me. It's a connect with me. Whatever disease I address, my first goal is to nourish. As a dietitian, I think I should look at how do I keep the patients nourished, hydrated, and going as per their medical nutrition therapy. And that's how, as a dietitian or a nutritionist, we start talking to a patient. When it comes to a topic like kidney, this was a generalized way I started looking at. When it comes to a topic like kidney, and we are today here to talk about metabolic syndrome, behind the scenario, a metabolic syndrome, we all know it's not the table or the forum to discuss that. But what repercussions that metabolic syndrome gradually has on chronic kidney disease or on the kidneys for themselves. Won't go much into technical terminology in a forum like this. But yes, we need to go background and understand that a long-term metabolic syndrome impact is definitely having a positive way of looking at your patients. What happens behind the scenes? I'm very much into molecular nutrition now. If I have obesity, if I have insulin resistance, if I have a very poor vascular health, my thought process goes in understanding if I'm looking at a kidney per se, how is my kidney getting affected? Maybe a pro-inflammatory response of cytokine, maybe more of renal ischemia. So neurologic, vascular, and somewhere trying to understand that is the fat, the inflammation trigger for a lot of areas in my health. And one of them is kidney. And that is why when I'm addressing a chronic kidney disease, it's not one size suits all. The guidelines are being laid for different areas of kidney disease. But definitely we need to understand if a byproduct of metabolic syndrome, long-term diabetes, long-term obesity is giving you a CKD, I think the diet should be very personalized. Immediately when it comes to kidney, uric acid, a patient comes with a prescription to us. I've stopped proteins in my diet. Protein stopping, I don't think is an answer to your CKD. So today, let's brainstorm. Today, let's sensitize ourselves. I cannot talk about a specific diet here, but we will look at the approach. A personalized way of looking at every patient is needed, and that goes hand in hand with the patient's medical conditions, the path reports, the clinical symptoms, not 1 + 1, 2. You have to eat a 30-gram protein. You have to go on an 1800 calorie diet. I think is not the way today. We are in an era of personalized health, and nutrition is definitely an important part of personalized health. So behind the scenario, if I'm having metabolic syndrome for 20, 25 years of my life, I know that I have a lot of
the molecular scenario which is disturbed in my body. Oxidative stress impacts my vascular health. There's a challenge in nitric oxide development, and we know that arginine is a precursor for nitric oxide. We know vitamin B12 folate plays a very important role in my nitric oxide generation. There is definitely increased renin-angiotensin system challenge, the aldosterone. So all that mechanism behind the scene, when it is giving me impact, telling me a creatinine is borderline, appetite has decreased, edema is there, slight change, the doctor diagnoses as CKD1, CKD2. Then the patient, and the doctor tells the patient, or the clinician tells the patient, go talk to your dietitian. She will help you plan a diet. That's it, he says. He may not even mention how much, what. I think today the clinicians leave a lot of emphasis to the dietitians to work on what they want to really look at. And when I am encountering a patient, and when I'm facing a patient, the patient comes to me dejected. He feels he's learned a lot about it through the Google. He says that's the end of the world. Tomorrow I'm going for dialysis. And then that makes him feel that I have nothing to left to eat. And me and you, at least in India, we feel food is connect, food is happiness. Food has some relation with us. And a CKD diet says, all what you like, you're not supposed to eat. It leaves us dejected. A CKD, a CVD, a diabetic, a diabetic should not eat a mango, but then I'm sure all diabetics do eat mango. So nothing like that. We need to really work as a dietitian to make you understand how much when, as the previous speakers have emphasized on portions. So let's understand when a patient comes to you, what is my goal as a nutrition therapist? I have to first look at his nutrition by preventing muscle wasting. Because first thing which attacks any CKD patient is a muscle wasting. So work on muscle wasting. And we all know protein and non-protein calories have to be segregated for muscle. I don't give protein, doesn't make sense. I don't give carbs, that also doesn't make sense. I have to spare proteins. I have to reduce the content of proteins, but Indian diets, do they really need a protein restriction is a question mark. We will talk about it soon. And then we start looking at what is the rate of progression of the disease. If needed, talk to the nephrologist and understand how he is looking, because these therapy is medical nutrition therapy. Nutrition therapy cannot be identified isolated like obesity. It has to be in conjunction with the doctors or the clinician who's attending. If the medical nutrition therapy says, go slow, talk to the patient, counsel him, give him time, talk what he needs to eat, look at his lifestyle and see the factors which will help him to prevent the progress of disease. That's it, that's my job. He comes to you with a prescription of creatinine 5 and edema and then chronic, then the scenario changes completely. So job one of a dietitian is prevent protein energy wasting. Because if I don't work on, because if he loses weight, there is definitely going to be an appetite challenge, because restrictions, appetite regulations, maybe whatever we look at, but the food intake is definitely going to decrease in such scenario. He has to eat. There is definitely a dopamine and a happy hormone scenario which helps him to recover. Let's look at the oxidative stress behind the sick, the inflammatory stress behind the scenes, and if your patient is coming with a metabolic syndrome, a metabolic stress behind the scene. At a cellular level, there's a lot of ROS. There's a lot of pro-inflammatory trigger, the cytokine. COVID has left us with really mind-boggling therapy that why one size doesn't, one COVID behaves such differently with each of us is because of the cellular chaos it creates behind the scene. And to create that chaos, maybe fat is responsible, genes are responsible, your food, your epigenetics, we do not know what. Then is it not a personalized way we are approaching? And a CKD diet, definitely we look at protein energy wasting to be avoided. Let the patient not lose a lot of muscles. As the previous speaker said, we have a nutrition care process in place. Screen your patient, talk to your patient, do the anthropometry, biochemical, understand. In a CKD, he comes to you with a lot of reports, he's confused. Doctor doesn't really tell him a lot of things because there's a lot of confusion because there's so much information behind the scene. So just understand the reports, work on clinical scenario. Appetite is the first thing which we will ask. तुम्ही पहिले 2 पोळी खात होता, आता 1 पोळी खाता का अर्धी पोळी खाता? Simple way to learn appetite. पोळी खायची इच्छा होती तर काय वेगळं खायची इच्छा होती. So it's trying to understand how the patient is looking at food. Is it a psychological impact or it is a it's a biochemical impact? If the creatinine is on higher side, metallic state, he won't be anyway eating at all. So appetite clinically, and then work on his recall. Because a true picture in a recent study said that a metabolic syndrome, onset of CKD, patient's BMI is 30-32. Doctor also doesn't tell him lose weight because he knows as the disease progresses, maybe there'll be a lot of impact of malnutrition. The challenge is nourishment trends, not the diet. So when the challenge is nourishment and you look at a typical calorie and a typical protein and try to tell him, just give a gist of how he has to eat in a progress first stage, second stage, and then we go on. Otherwise, we will be actually giving him a lot of muscle loss because there'll be an inevitable weight loss in a chronic conditions like CKD. The focus should be on energy intake. He should be minimum. If he's overeating, fine, but I'm sure clinicians agree with me, there's no overeating in this kind of cases. One is mental stress, and two is patient cannot eat so much. And then look at how much energy he's eating. Basic BMR energy, he has to eat 25 calories per kg body weight. And a typical diet recall helps me to understand. In that recall, let me understand what is his basic protein intake in his diet. Varan amti asal ta hardly any protein intake. Rasam and amti don't carry protein. So there's no point for me to tell him that don't eat dals. How many eggs a day? How many, just try to understand his milk, egg, non-veg intake if he's indulging into it. As there's a lot of discussion on fat, ask which oil, and when visible fat should be 50% of your total fat percentage. Visible oil is 50%. Your total energy is 1800. Out of that 25-30 can be your fat. Out of that 15 to 20 is your invisible. What is left is just 10% of your visible fats. So je paije te tel kha, fakta rotate kara, mufa techa jasta rahela paije. So as she said, olive, we can have mustard, we can have but more than quantitative approach in a particularly CKD cases, 10% of visible fat can be rotation of the oils and 1 to 2 teaspoons of ghee. We do say because it has some, SFA also contributes. We all know that 1:2:1. So 1 is your MUFA, sorry, 1 is your PUFA, 2 is your MUFA, and 1 is your SFA. So there is an SFA contribution and we want that to come from a good sources. A clarified ghee is a good source of SFA rather than going for other sources. We cut down on other animal fats. So we start looking at sodium, potassium, and water intake. That's all. Getting too much into detail of reports will be with the biochemical parameter. If his phosphorus is high, if his calcium is high, anemia we don't manage because we know that hemoglobin is going to be less. So counsel the patient to work on the basic structure of medical nutrition therapy in your kidney diseases. And then personalizing the diet. Goals should be very specified. Weight management, prevention of muscle loss, and basically, I think good communication with the patient. Give 15 to 20 minutes to the patient. I urge each clinician here who can tell their patients, "Tumi dietitian baro ver ghalwa." Talk to them, listen to them, don't argue with them. Because at least in today's era, when a patient comes from a doctor to us, he always has his own way of looking and saying that "Tumi fakta kai khaisa, doctor ni pathole म्हणून आम्ही आलो." So more than doctor ni pathole, मला गरज आहे समजून घ्यायची काय खायचं म्हणून मी आलो, has a better way of looking at it. So one liner from a clinician always help for a dietitian to counsel because it leaves a positive impact on the patient. Because end of the day, it's a communication and a counseling game on what to eat, how much to eat. So we start with a little thought process of medical nutrition therapy here. As I've already said, my goal is to give him minimum calories, what he needs. And calories are personalized. And we all know the calculation goes as 20-25 per kg, ideal body weight, calculate his ideal body weight and work on it. And then don't push too hard on not eating here because already the patient is not really in a mental state of asking for you that it's not obesity management or it's not a lifestyle management. It's more of a CKD management. So if your patient gives you a typical recall of what we eat at home, breakfast, lunch, dinner with the normal calorie intake, 1850 gram protein. So first chalk out and explain to him, see, this is what you've been eating. You're eating 2 chapatis with your chai, and this is a typical diet. I mean, the diet can change. 2 chapati with bhaji is your lunch, varan bhat, you can add an egg, evening some snacks, and some bhakri and bhat. And I'm sure all of us have typical appetite of this. We all end up eating 1600 to 1800 kilocalories, and look at the protein content of 50 gram of protein. And I put more emphasis on now looking in this chart, how do I change it? Because patient comes to you with a CKD diet. He says, counsel me for a kidney disease. Then I have to highlight proteins here because I know that I can't play with his creatinine and clinician is looking at me to work on his renal parameters. So my protein says, as it is 50 grams of protein, how much is a useful protein for him? So I divide the protein and said 50% of the protein is high biological value protein. And I try to give him a chart of an exchange list. We have something called as exchange list where we try to tell him the options. 3 egg whites is equal to 300 ml milk is equal to a 50-gram chicken. And 2 of this you can have every day. That becomes very easy for the patient to learn to calculate his own protein intake. Like for a type 1 diabetic, we'll have a diabetic session soon. We teach them carbohydrate counting. I think for every patient, the nutrient which is highlighted in his diet should be taken as an exchange list. A 10-gram protein exchange list, tell the patient, hey, 20 gram khaiche. Dialysis, hey, 40 gram khaiche. The protein can keep changing as per the CKD 1, 2, 3, 4, 5, whatever it is. But then that exchange list is a very convenient, handy way for a patient to learn that, okay, 10 grams comes from 3 egg whites, 150 ml milk gives me 5 grams of protein. I'm allowed 300 ml. So 2 katori curd and chai, coffee. Try to explain him, milk is not just milk. It is chai, coffee, everything, because casein is not destroyed in the milk, tea. So it's a protein, calcium, and can the bioavailability changes of micronutrients, but not the macronutrients. So explain to your patient and give him a protein allowance. Generally 20 grams of HBV protein and CKD works. So going back to the previous slide of his diet and asking, looking at his, what is an HBV here? Hardly any HBV. 1 egg or a curd, I don't see much. And that's a typical Indian diet. An aware person can eat little more non-veg or 1 or 2 times, but the non-veg is more of gravy. I'm talking from a patient point of view, and we are healthcare professionals, and we know that we need to add more fiber, more protein, and all that. So challenge at a dilemma with a dietitian when she's planning a diet is, do I really put a protein restriction? Do I really tell the patient not to eat proteins? This happens in hyperuricemia cases also, friends. So this, am I putting the patient into my malnutrition? And as a clinician, I want you also to understand us that we are trying to tell the patient to quantify their protein intake. Because many a times patient goes back and tell the clinicians, "Amala under dietitian is khaila sangitla." Then under kasa sangitla uric acid jasta hai tumse. So I think that kind of a dialogue which a patient and a dietitian has, quantifying the quality of the protein of 20-gram allowance, justifies that he can eat variety. And that's my job, I feel, that giving a patient variety and training him to understand that what kind of quantitative approach for the nutrient which he really has to restrict is very, very important. And I'm sure all of you agree with me at this stage. So at a CKD level, what I look at it now in this stage is I have given a 20-gram protein HBV, and we try to look at. I'm not a very great fan of paneer here because for me, 100 grams of paneer is a 500 ml milk background, and we all have been reading about saturated fats contributing a lot to NASH, to adipogenesis, to CVD. So I think we should start looking how to minimize a saturated fat in my diet. If I'm drinking a 500 ml milk, my ghee gets out of my diet. So I think that balance I'm creating, I'm not trying to tell you that ghee is good or that saturated fat allowance can be 1 to 2 teaspoons a day, and milk and egg yolk if you're eating. So for me, nutrition is important. I would say eat an egg yolk and cut down your milk. So somewhere we are trying to balance it. And this is what I try to work with my patients. So as the disease progresses, stage 3, stage 4, and 5, and you've seen that the HBV protein increases, and it's easy. Patient knows if the doctor says 40 grams, he'll pick up 20 from that HBV protein and he'll manage his own protein intake. So I think this is where we have to start boiling down to give a variety to my patients. The next macronutrient I look at is lipids. Won't go into detail because kidneys, osmolarity of fat is the best thing. So we all know in TPN and all, fat is our favorite. In EN, the fat is our favorite because it helps me to get calories. It helps me for the osmolarity of the feed. But I'll definitely see that my saturated fat in the diet is not contributing to my fat intake because of the risk of dyslipidemia in CKD. And definitely the N6, N3 ratio, as the previous speaker said, it makes a lot of difference to have a good N6. Why we are into an inflammatory trigger is maybe the N6 in our diet is too much than N3. So do we really need to put more emphasis on N3 or cut down on N6? is something we need to balance. And I think your nutritionist or dietitian could help you do that depending on your recall. So personalized approach tells me that, yes, I need to work on macros and I need to see that, train the patient to eat good amount of complex carbohydrates. Eat well plate, as our president the convener told that, yes, eat well plate is half plate vegetables. Basics, I think that's what the nutrition needs today. Emphasize on fiber. Restriction of potassium, sodium has made the patient not to eat vegetables at all. We can't outdo the effect of fiber in my diet. We are in an era of promoting plant food, phytonutrients, gut flora, prebiotics. Your body has its own gut flora. Probiotic may not help you to give that gut flora. Prebiotic background helps. So I cannot ignore my fiber. I will tell my patients, don't vata bhaja. Potassium depends on leaching or not leaching. We will talk about it, but fiber cannot be omitted. So again, the plate system remains the same. Half plate is vegetable, even in a CKD diet. Maybe some electrolytes here and there, I can balance it. But I cannot ignore fiber, because the clinician will agree with me. There's a lot of gut issues. Constipation is a major issue with it. Less hydration, constipation, patient gets irritated with it. You give more of stool softeners or more of fiber intake. Why don't I put vegetables in the diet? Maybe I give more of prebiotics and phytonutrients, which might help it. The next micronutrient, the next electrolyte element is very important, which is sodium. Challenging because the taste comes with salt. And again, a dietitian's role is make your food interesting, give you counseling, give you variety, but keep the medical nutrition therapy in mind. The previous speaker said 5 grams is what is being recommended, and doctor knows that 2 grams is in CKD. It's a blanket prescription, 2 grams sodium. A 2 gram sodium is such a challenging if I keep asking patient to measure the salt, because we all know if I eat one day salt-free diet, I'll feel so irritated. Vasna manto, the appetite changes. And feel good with food is very, very important. Food has to be happiness, satiety, and satisfaction. And that is why I feel that train the patient to say that do not use salt which is higher potassium intake, Lona, because they know that sodium, I can use Lona salt, pink salt, or whatever salt which has come in the market. Iodized salt, but don't add top salt. Because if you calculate your calorie intake, you won't go beyond 2 grams. Eat normal food, avoid adding salt in your atta, in your chawal when you're cooking. These are the small instructions which will give it to them. Try to see how the restrictions can be making them happy rather than making them more deprived. And then we try to tell them, but definitely tell them, educate them about the calculation of the sodium and salt. And when you're eating a packed food, and it's very nice to tell them that, see, this is your sodium allowance, this is a packet of biscuit, now calculate. Ask them to calculate. It will be more of eureka for them, who we've never realized that 2 biscuits is contributing to almost 0.5 grams of sodium in my diet. And that 0.5 gram calculation, when they actually do it, it's easier for us because it's all about neuroscience, 80% taking over your diet. I've come to that conclusion now that neuroscience needs to be trained, body becomes easy to handle. Because otherwise you go in terrible deprivation and depression when your body says do not eat. And then some calculation with sodium and water balance, some calculations. I tell them, okay, how much has your doctor asked you to drink water? We definitely have to ask what are the instructions of the nephrologist. And according to that, try to balance the sodium and water and try to see that and train and educate the patient about his urine output plus 500 ml. Maybe every time he may not like to calculate, none of us would like to. But if you feel that you're urinating well, the doctor says 1 to 1.5 liter. If you are anuric, definitely the sodium changes and the whole management changes. So urine output is a judgment of the patient, which the patient tries to tell you. And then you balance the sodium as per the urine output, 2 to 3 grams, 2 grams, or less than 2 grams. And then there are tips. Patient wants to drink water. Patient is anuric. Doctor says, do not drink water. Dietitian should have these tips handy for keeping your patients happy. Keep ice in your mouth or some kind of mint, some gels. There are a lot of things which helps the patient to feel hydrated with the dry mouth which they are facing. The potassium is another electrolyte which we try to work on, but today the papers say potassium restriction should not be emphasized. Definitely leafy vegetables, coconut water, fruits have to be quantified. Try to avoid coconut water, give 1 fruit allowance per day, and if their potassiums are normal, less than 5, what the blood parameters looks like, and leafy vegetables, if you're regularly eating, because we are talking about fiber here, and potassium is subjective to change in your cooking, and you do not actually get one potassium which is written in your IFCT, that is the food table, the amount of potassium. IFCT has a very less amount of banana in 2010, and today in 2020 they tell us the banana is a very good source of potassium. The dietitian
Excuse me, ma'am. You have 5 more minutes.
Yeah, I'm done, sir. The last nutrient here. Thank you for this. So the potassium itself becomes a challenge for me to understand that how do I compensate? So because potassium, go back and learn about what are the practices in cooking which leaches your potassium. Maybe soaking. So soak your dal, remove the water, and then cook it. You minus your potassium. Maybe you can't count it. But this tips helps for controlling the potassium, but not minusing in your diet, telling the patient not to have it. But few areas like fruits, which cannot be leached, or coconut water, which is definitely a source, and also a source of liquids in the diet, we work on it. But otherwise, talking about not eating a salt which is high potassium, something works here. And the potassium chromate, which is added in your processed food, is also another contributor for your potassium intake. And yes, there are exchange list of low potassium, medium potassium foods, which your dietitian definitely has in her hand, and it's handy. It is generally being worked with all the renal dietitians who are working. But end of the day, potassium, phosphorus, calcium, proteins all go hand in hand. If I'm restricting proteins, I'm definitely restricting potassium and phosphorus. So definitely these two go hand in hand. So go interrogate your patient. If your phosphate is very high, talk to the patient, interrogate, outside did he eat anything? Chahe doodh ki banti, aadhi doodh, aadha pani. End of the day, these are few tips, but only when your blood parameters are high. Don't make the patient feel guilty that he's consuming too much if the blood parameters are normal. Talk to the patient, counsel, it works. Multivitamin is generally not a very usual prescription post-session. I would definitely ask the nephrologist to comment here. We don't give any supplements to the renal patients, neither we would like to, because it's not our purview for a CKD or a liver patient to give a supplement. But somewhere, the multivitamins, we understand the nutrition, we know that patient is malnourished. And we know that the malnourishment is a micronutrient deficiency, not the energy deficiency. And we want a clinician to identify these areas of support to the patient and work on it, because food will not give adequate micronutrients. You're taking care of iron, erythropoietin, or looking at the parameters, but we miss out on major B complex, major water-soluble vitamins, and some fats. So vitamin D is taken care of, but other macronutrients we do not. So definitely we would like your inputs on it. And if you want a dietitian to help you or help patient there, we are ready to do that, because somewhere that teamwork and looking at not making the patient finally malnourished is the goal. So end of the day, friends, I think here I am to tell you an integrated approach towards nutrition. Molecular scenario behind the scene needs to be understood what stress the patient is in. Is the patient in metabolic stress, inflammatory stress, or oxidative stress? Your blood parameters, patient's symptoms, patient's challenges with his own body of appetite and exercise, fatigue, energy tells us everything. So a holistic approach of way of looking towards a patient is always beneficial. A teamwork is important, and a nephrologist should always have a renal dietitian who can counsel and give time to patient. But there's a mutual respect for each other. When a nephrologist puts in a word, a clinician puts in a word, listen to your dietitian. So it makes a lot of impact for a dietitian when a doctor says that listen to your dietitian, don't ask me the diet tips. And you talk to the dietitian telling what you want to tell to the patient, because the counseling becomes more easier for us. Thank you so much for the patience.
Thank you so much, ma'am. Very articulate and very nice presentation. Maybe please have some expert comments on this.
Thank you, ma'am. It was wonderful. It was
So my question to you, sir, if you can answer that, a micronutrient support, how would you look at it?
Especially in dialysis patient, we had micronutrients. All the patients are, because from the membrane, we tend to lose lots of B complex and water soluble vitamins. So usually most of us or dialysis patients are on supplements.
What about CKD, sir?
CKD also, most of the times they are there.
So if you would like a dietitian to intervene and give a supplement, can she do that, or you want a nephrologist to do the job?
If from diet, it would be very.
So a simple multivitamin, will it harm the patient if you give it to the patient?
Multivitamin.
Because we are looking at a micronutrient deficiency, a simple, any supradane or B complex, which is not a.
Most of the times these people have in their prescription.
So suppose it is not there, can a dietitian intervene and write the prescription?
Why not? No issues.
So this message is for all my fraternity here who's listening to us. Thank you. Yes, sir. More comments.
what practical, all were practical this thing. म्हणजे तर त्यातलं बऱ्याचदा आपण असं बघतो की मोस्ट ऑफ द पेशंट्स कम फ्रॉम, म्हणजे आमच्याकडे जाऊन आणि त्यांच्याकडे जाऊन दोन्ही वेळेस म्हणतात की आता खाऊ काय, सगळं तर तुम्ही बंद करून टाकलाय. तर मोस्ट ऑफ द टाइम्स यू हॅव टू, बऱ्याचदा आम्ही तसं म्हणतो की हे जे आहे त्यातलं म्हणजे जसं आपण म्हणतो की जे डाळी आहेत, बऱ्याचदा मॅडम जसं म्हटलं की डाळी जे आहेत ते यू कॅनॉट काउंट ऑन मच ऑफ प्रोटीन्स इन दॅट. म्हणजे डाळ तर भातासोबत तेवढी लागतेच त्यांना, आणि त्याला आपण असं बऱ्याचदा घट्ट वरण ते घेत नाहीत ते. आणि दुसरं असतं ते मीठ. तर सॉल्ट ॲज मॅडम सेड की इट शुड बी जस्ट जेवढं चवीपुरता टाकायचं तेवढं टाकायचं, वरनं टाकायचं नसतं. आणि आजकाल नवीन फॅड आलाय ते सेंधव मीठ खायचं का मी, और इवन टाटा हॅज ब्रॉट वन लो सॉल्ट हाय पोटॅशियम वाला. So these are the problems with patients nowadays. So they, without telling us, they will start the Sendho meat and then they come up with a potassium of 5, 6 or 6.5. So that should ideally be avoided, and that should be counseled to the patient. I think rest of the things madam has covered. Thank you.
So as I said, I leave it to the clinician to tell me how much water the patient can have. So appearance of edema, sir, how would you look at the hydration? I'll tell about how much water I can give. It's more of a symbiotic.
Basically, whenever there is edema, that is excess fluid in the body. So you have to decrease the intake and increase the output. So if in dialysis patients, whenever there is edema, and all dialysis patients, the restriction is around 800 to 1 liter.
So you're talking about albumin, generally hypoalbuminuria or malnutrition. That's where I think sir is coming from. Oh, that's more of malnutrition, sir. That's more of protein malnutrition, which we talk about. So we talk about calorie intake. The edema can be well taken care with. No, one egg is 6 grams protein, egg white is 3 gram protein. So you start calculating that how much protein you need it, and then we try to look at. But egg may not control that edema. Just look at calorie and non-protein calories. Protein calories, non-protein calories. End of the day, this is because of hypoalbuminuria. Hypoalbuminuria is not because of albumin is less, it's because you're malnourished. The malnourished can be weight loss, can be micronutrient deficiency, can be chronic illness. It can be any reason for that. So in that case, go back and learn about patients' recall, intake, calorie intake, work on at least contributing to good amount of nutrition and supplement micronutrition. And if needed, go for a PN of albumin or some EN feeds or whatever. But end of the day, it's nutrition which will make a difference in a hidden edema of malnutrition. Nephrotic syndrome is a very high protein diet. So 1.5 gram per kg is what we say, more than that also.
And basically it is the cause of, the treatment should be started. If you treat the nephrotic syndrome, if you treat with steroids or whatever the cause of the nephrotic syndrome, I think the edema usually disappears. It is not only, it is not like 10 grams जा रहा है तो आप 10 gram खिलाओगे तो अच्छा हो जाएगा.
और पीडियाट्रिक का कैसा रहता है सर, वेट भी कम रहता है. So 30 kg child can definitely eat 2 eggs, which is comfortably, or 2 katoris curd. So we push little more extra high biological value protein because there's a protein loss in nephrotic, and parallelly go with the treatment. So the cause of nephrotic syndrome can be corrected. Then one fine day we don't have to work on protein, we have to work on weight management then.
If you see the Indian diet, we have done a study in Mumbai where we used to have our OPD and the dietitian used to sit there. And for every follow-up, we used to, पिछले एक महीने में कैसा खाना खाया, just what madam was telling. So it was found that Indian diet doesn't contain much of proteins. Our this was 0.3 to 0.6 ही खाते, कितना भी हम लोग अगर 0.6 to 0.8 is actually prescribed in a CKD patient. So and 0.3 to 0.6 is actually VLPD, that is very low protein diet. So there was a major chunk of patients were in that VLPD because once they diagnose CKD, उनको पता है कि नहीं अभी सब बना है, वो एकदम खुशी से बताते हैं कि I have not taken dals for the last 1 month, so my creatinine should come down.
So just to add on to this, sir,
big
2020 says for a normal adult 0.5 to 0.6 gram per kg body weight. But what's important is amino acid profile of your food. It's important that you include all the essential amino acid, and dal has the highest lysine. Contribution of lysine in 1 gram protein is very high. 30 mg is what a lysine contributes.
So a lentil in your diet definitely contributes a good essential amino acid, because end of the day, we are looking at protein from essential amino acid. That's why we are saying HBV. And BCAA lysine contributes to maximum amount of amino acid profile to your protein. And now we are working on DIASS. We are not into now pedicast. We are looking at the ileal absorption of your amino acids. So it's called as digestive ileal amino acid score, which says how much amino acid profile is my ileal absorption is happening. And in that, milk scored the highest in DIASS. We have pedicast, we have the HBV protein. So milk casein protein is the best protein which has a very good amino acid profile. And lentil score in lysine. And if you look at lysine, it contributes to the most of your amino acid profile, more than your sulfur containing amino acids. So the very much important, it's very challenging. So eating, that's what, when you eat protein, we don't know how much protein your body is using. So when you eat protein, how much is your DISS and how much is contributing? So if 0.5 to 0.6 is the present guideline of 2020, you should calculate the contribution of good quality proteins, at least a 50% of your total requirement, because that will justify your complete profile of essential amino acid which you're looking for.
I'm sure all of you have quite a few more questions. That's a very interesting session going on. But since we are running short of time, I have to.
So before we conclude, I'll just make a quick comment.
Yeah.
The point that she has brought out, it's very, very practical and very important that we as doctors, as she mentioned, we know 2 grams of sodium is to be given. We just prescribe it. But there's a gray area in our prescription and what dietitians prescribe and what the patient understands. So I think we are doing these series since last 5 years with IDA, and we are trying to address this problem that the gray area between doctors' knowledge of diet, dietitians prescribing what doctors want. This is what we are trying to address, and I'm sure that IMA also would be a good platform to bridge this gap. Thank you, ma'am.
Thank you so much, ma'am. Please, organizers.
Thank you so much, Geeta ma'am. It's a pleasure to listen to you every time. This was an enriching session, but I think we have to take the questions later on. Now I would like to call upon Dr. Meenakshi Deshpande, who is the president of IMA, to felicitate Dr. Geeta Dharmatti. Yes.
Very nice job, madam. And I hope we meet again in for 2 years. All the faculties and chairperson, please wait for a group photo.
I would request Dr. Arekar to continue to chair the next session. Dr. Meenakshi Deshpande is already here. Can I please have Dr. Raju Varyani to come on stage to felicitate Dr. Sunil Zawre? Thank you, Doctor. Could I ask Dr. Raju Varyani to introduce the next chairperson?
We now go for the next talk, which is on practical updates in diabetes management. To chair the session, I invite Dr. Chandrakant Rao. Dr. Chandrakant Rao has done MBBS and diabetology from Mumbai. He's also attached to Wise Diabetes and Research Center. He is consultant of diabetes in pregnancy clinic at Gupte Hospital, Pune, consultant Ruby Hall, Vanavri, Pune, also consultant at Inamdar Hospital, Pune.
Thank you so much. It's my pleasure to invite the next speaker, Dr. Tejas Limay. She's a consultant nutritionist and Joint Secretary Joint Secretary Pune Chapter IDA. She is an MSc and a PhD in health sciences and registered dietitian and certified diabetes educator. She holds a first rank of Savitribai Phule Pune University, recipient of Inspire Fellowship DST, and total 12 papers published in international and national reviewed journals. She has several affiliations. Happy to have you over, ma'am.
Thank you for the warm introduction, and thank you IDA Pune chapter IMA for this great opportunity. I think I'm quite junior amongst you all, but yes, I would like to share my experiences when it comes to diabetes management, as I have more than 10 years of experience dealing with type 1 and type 2 diabetes patients. And as we all know, diabetes is the prevalence of diabetes is increasing like anything. India is known as second capital of diabetes, and more than 10% of adult population is affected by type 2 diabetes. The fact is that only 50% of the people are diagnosed, those who have diabetes, and out of those who are diagnosed, only 50% are on treatment. Out of those who are treated, only 50% they have their diabetes under control. So only 12% of diabetic population is well controlled. So that's the fact, and we need to really do something about it. The research from our own unit says that Indians are susceptible to type 2 diabetes at a younger age and lower BMI. So even if the person is not obese, he or she may still have high fat and predisposition to type 2 diabetes. So I think nutrition is one of the important factors when it comes to diabetes management. And you all will agree, diabetes management is a team's job and a multidisciplinary approach where diet, exercise, medication, regular monitoring, sleep and stress management are all important, along with awareness. So it's a team of dietitians, exercise experts, doctors, of course, and psychologists, along with diabetes educators, make a perfect team for diabetes management. So let's talk about diet today. I'm not going into pathophysiology and medical terms, but yes, I would like to share more practical experiences when it comes to diabetes management. So nutritional therapy goals for diabetes management may not be only glucocentric. So it may not be just improvisation of glucose status or blood glucose, but along with that, it's very important to have good goals for blood pressure, lipid management. Ideal body weight achievement is one of the important points when it comes to diabetes management, because diabetes is very closely linked to weight, and even diabetes control improves drastically when a person improves with his weight. Complications of diabetes can be prevented with a good diet, can be managed quite well with a good diet. And diet is important when it comes to variety, portion size, cultural preferences needs to be considered. Pleasure of eating. All speakers have mentioned this, that diet is not just food, but it comes with pleasure. So need to consider that. And important is to spread health literacy and awareness when it comes to nutrition. So principles of diet, I'll just discuss important principles and then I'm going to talk about practical things. So to keep it short, calorie calculations can be based on weight. So if weight loss is a target, then calories can be calculated accordingly. Important part is carbohydrates. So carbohydrates, they reflect to your blood sugar level instantly and rapidly. So glycemic index is important, but along with that, glycemic load is even more important. That's what I always feel. Glycemic index is how fast blood sugar will increase after consuming a particular food. But when it is combined with the amount of carbohydrates, it becomes glycemic load. So glycemic index as well as amount of carbohydrates, when you consider both, then blood sugar management becomes even more better. So it is observed that total amount of carbohydrates has very strong influence rather than quality of carbohydrates. So recent papers, they are saying that yes, patient can eat their favorite food, but if the quantity is kept to minimal or kept at a good limit, then yes, all foods can be eaten by a person with diabetes, but glycemic load matters the most. Carbohydrate counting, therefore, is a very useful tool for management of blood glucose levels, especially in type 1 diabetes, also in type 2 who are on insulin treatment, and also type 2 patients who are on OHAs, and where dietitians and doctors can interact and adjust the OHA doses based on the carbohydrate content of the food and response on blood glucose levels. So there are some important factors to consider when it comes to carbohydrates. Complex carbohydrates are always better, but fiber intake is very much important. And if every meal can contain good amount of fibers, then glycemic response is much better. So even a new term, or not a new term, I would say, but very popular term nowadays is resistant starch. So if your meals can contain some resistant starch, that can reflect in good glycemic control. So it may be through different sources like boiled rice or raw banana flour, or you might have heard about jackfruit flour, raw jackfruit flour. I'm coming to rice later, but yes, such resistant starch sources can be of great use when it comes to blood sugar management. Coming to proteins and fats. So fats, the goal or the content quantity should be individualized, but quality is more important. Limit amount of saturated and trans fats. Amount of fats can be 20 to 35% of total calories. Fats are important because they are a source of fat soluble vitamins, but along with that, they give good satiety and flavor to your food. So satiety is very important when it comes to diabetes management, because if the patient is not full, if he is not feeling fullness after a food, he is very likely to have food every now and then, and that reflects on his glycemic control. So it's very important to have good satiating food when it comes to diet for diabetes. Proteins have similar role. They are quite filling, but proteins can be up to 1 to 1.5 grams per kg of body weight and up to 20% of total calories. Diabetic kidney disease, proteins can be little less, but as Geeta ma'am told that, yes, we already take quite a less of proteins. So we need to really include proteins in a diabetic patient's diet when it comes to regular management of type 2 diabetes. Vitamins, type 2 diabetes, we all know it is a state of increased oxidative stress. So doctors and dietitians are tempted to introduce some antioxidants in diabetic patients' routine. But the research says that no benefits of antioxidant supplements for improved glycemic control or treatment of complications. And also, there is no adequate evidence for routine vitamin D and vitamin B12 supplements without deficiency. So it's better to check the levels first and then decide whether to supplement D and B12. Most of the cases you will find deficiency, but unless there is deficiency, there's no point in supplementing, especially those who are on metformin therapy. They may need B12 supplements, but again, the guidelines say that it's good to check B12 levels before supplementing anything. Minerals, again, routine supplementation is not recommended. Previously, magnesium and chromium supplements were quite popular among people with diabetes, but there's no strong evidence to support magnesium and chromium supplementation. Important mineral is sodium. So as people with diabetes are prone to have cardiovascular diseases and high blood pressure, it's good to limit sodium to 2,300 milligrams of sodium per day. So this was all about theory part. Now I would like to go to the practical perspective. And your common question will be, can people with diabetes have rice? And that's the most important food people will always stop or quit from the diet. When diabetes diagnosis happens, first thing people will do that they'll quit rice. But they'll come to you, they'll ask you, can I eat rice? And as a nutritionist, if you say no, they won't avoid rice, but they will avoid you. So it's your duty to tell them in which form they can eat rice, which rice they can use, and how much. So when it comes to rice, it is known that short grain rice, the glycemic index is higher. So as the grain size increases, the glycemic index decreases. So long grain rice is a better choice. So basmati rice. Even short grain brown rice is little better. Long grain brown rice is even better. And I was talking about resistant starch. So if you know boiled rice, so boiled rice is the rice when the rice is boiled with the cover and then cooled, cover is removed, and that rice is used. So that rice has good amount of resistant starch and has better impact on blood sugar levels compared to other types of rice. Patient will ask you, can I cook rice and remove the water? Will that help? We tell them, yes, you can do that. No need to worry about the micronutrients. People will ask us that, yes, if we remove water, are we not losing all important vitamins? So my answer to that is rice will already have, the white rice especially, will already have very less vitamins and minerals. During polishing and processing, most of the vitamins are lost. So why not remove water? You include good amount of other sources of micronutrients like vegetables, fruits, grains, whole grains, nuts, but no need to worry about micronutrients in white rice and removing water, but because removing water is known to reduce starch content of the rice. Secondly, now the new studies, they are come up with another preparation of rice, another method of preparing rice, that is adding 1 teaspoon of coconut oil while cooking rice and then removing water. That has been found to have better impact on blood sugars compared to any other methods of cooking rice. So such practical points, if you can give patients and tell them to have rice in limited quantities, of course, it will definitely help them have better choices and give them the pleasure of eating rice. So especially South Indians, Bengalis, they can't do without rice. So I think for such population, you need to really have good guidelines when it comes to rice. Now, gluten-free diet. Yes, people are quite fond of gluten-free diet when it comes to diabetes. Many people have started consuming gluten-free diet just because they are diagnosed with diabetes. Is it really required? Gluten-free diet is good for whom? Those who have sensitivity to gluten, those who have celiac disease, not for everyone. So 10% of those with type 1 diabetes have celiac disease because both are autoimmune conditions. But when it comes to type 2, there is not really good relation with type 2 and celiac disease. So unless you are sensitive to gluten or unless you have celiac disease, I think there is no need to restrict wheat from your diet. People, they would like to shift to millets when it comes to gluten-free, or even otherwise. Once they are diagnosed with diabetes, they shift to bhakri instead of roti. But if you ask me, bhakri will increase sugar more than roti. Why? Because some millets, which are very commonly used in India, in Maharashtra, like jwari, nasni, both have higher glycemic index than roti, than wheat. Secondly, glycemic load of bhakri is more than roti. Why? Because bhakri is thicker in size, thicker in appearance. So it will have more grains, more grain quantity compared to roti. So I think from both perspectives, shifting to bhakri may not be a good choice when it comes to diabetes. If you are planning to shift to some other millets like foxtail millets or quinoa, yes, such are better options, but in Maharashtra, that's not very commonly used. So that was about gluten-free diet. Fruits, yes. So free fructose, which is naturally occurring in the food, it also contains fiber, antioxidants, vitamins, minerals, and it may result in better glycemic control compared with isocaloric intake of sucrose and starch. So it is not likely to have detrimental effects on triglycerides if intake is not excessive, if it is less than 12% of energy. So fruits are always blamed when it comes to diabetes. People will tell you, especially those 5 fruits you all must be knowing: mango, banana, sitafal, custard apple, grapes. So I think that guideline is now outdated. As Geeta ma'am rightly said, in mango season, every diabetic person will eat mango. But to address that, it's good to counsel patients which type of mango, what is the quantity, what is the right time to eat mango. So generally, the guidelines say that, yes, quantity of fruits matter. So if it is mango, limit it to 2 to 3 pieces. Have it between the meals and not with the meals. If you eat amras with roti, yes, definitely it will increase your sugar. But if you want to eat mango, you can have it between the meals. And yes, 2 to 3 pieces will definitely be fine. Your sugars won't rise. If you have it before exercise, even better. Ripeness matters. So when it comes to fruits, the ripeness is very important. More the fruit is ripened, it will have more carbs, easily digestible carbs. So right ripeness is important while choosing fruits for people with diabetes. And I always say that use glucometer, which is your friend. And nowadays you have better technologies like CGM to see which food influences your blood sugar in which way. Even I have started using it. You can see it on my arm. So I experiment with different foods. Even if I'm not diabetic, I can see many fluctuations in my blood sugar level after consuming different foods. So I would really suggest every nutritionist, and if possible, even the doctors, to experiment with CGM yourself, and you'll be better equipped to give important guidelines regarding diet and what to eat and what not to eat. So it serves as a great tool. When patients see their records on mobile or on the reader, they will be quite sure whether which food, increases sugar in which way. So I always call it a difference between glucometer and CGM as a trailer and a movie. So checking sugars with glucometer is like a trailer. You pick different points, but CGM is like an entire movie. You see the entire picture. So I think it's good to use it and see how different foods affect your sugar. Coming to dairy. So generally dairy products are encouraged for prevention of diabetes. There are many studies which say that dairy products consumption is linked to prevention. Fermented dairy products are more beneficial, it says. Using low fat milk was generally recommended so far, but now it's debated. Even full cream milk is now considered better because it gives more satiety. A1 versus A2 milk is still a controversy. There is no evidence for type 2 as such, some evidence for type 1 and cardiovascular diseases. But in India, where there are no regulations on A2 type milk, no food labeling, no authenticity, it's difficult to follow guidelines about A2. Alcohol, yes, diabetic people are quite interested about knowing alcohol guidelines. So recommendations about quantity, though they are similar as for general population, diabetic people have increased risk of hypoglycemia, especially delayed hypoglycemia, and especially if the person is on insulin or insulin secretagogues. So symptoms of hypoglycemia, they look similar to drunkenness, so can be missed, and hypoglycemia management or treatment may be delayed, and it can lead to serious complications. Weight gain is an issue with alcohol. Hyperglycemia can be a case in case of excessive consumption, especially with snacking. And finally, the alcohol is addictive. So I think considering these points, alcohol guidelines should be given to the patients. Herbal supplements, yes, nowadays there are many supplements in the market which say that cinnamon, methi, curcumin, other spices, they're diabetes friendly, they will improve insulin sensitivity, they will help diabetes management, but there is no enough clear data to substantiate. And it may cause more risk or more harm than good if it is not formulated. Many products in the market are not formulated as per the guidelines. Many people will consume these spices in very high quantities and then they'll come up with acidity and other issues. And some of them can interact with OHAs. So it is not really recommended to have them in too much of quantity, but yes, as a, along with your good diet, you can have it as a, secondary thing. It's not a magic pill, you should remember. It's not alternative to a good diet. So overall quantity of diet and quality of diet is more important than consuming such herbal supplements. Sweeteners, there are 7 non-nutritive sweeteners approved by FDA. Commonly used ones are aspartame, sucralose, and stevia. They do not increase sugar level, but the food in which you add sweetener, it matters the most. So people will add sweeteners to all calorie dense and carb dense foods, and then they will complain that sweeteners are not working. I can see high sugar levels even after adding a sweetener. So sweetener is not responsible for that, but other ingredients in the food that has to be considered. And now there is much talked about diabetes remission. So one important trial called as direct trial has shown that diabetes remission is possible, especially in the early years of diagnosis. And it depends on the personal tolerance for fat levels in the livers and pancreas. So those who could achieve good weight loss, for them, the remission was possible. And it's called remission and not reversal nowadays, because diabetes can reappear after a few years, but at least it can be, away for a few years. And remission is durable till weight regain is avoided. And to achieve remission, dietary strategies plus increased physical activity, both are important. And what is done for diabetes remission? So in that trial, energy deficit diet was given, only 610 calories in a day. Out of them, 510 calories were given as liquid formula, so as a meal replacer, and 100 calories as non-starchy vegetables. So around 59 grams of carbohydrates, 11.4 grams of fats, and 41 grams of proteins were given throughout the day. Fasting glucose normalized within a week. 15 kg weight loss was observed in 8 weeks, those who followed this kind of diet. And diabetes remission was possible in half of the cases. So sustainability is an issue, but this trial has shown successful remission of diabetes at 6 months with isocaloric diet. So once the patient has achieved 15 kgs weight loss, they have been given isocaloric diet to maintain that weight. And at 6 months, it was found to be useful or effective. And we are going to talk about bariatric surgery later. So that can be one of the ways to prevent.
You have 5 more minutes, please.
Yes, sir. Last 2-3 slides. So bariatric surgery can be a good way to for remission, but we are going to talk about it later. So I think we need to work on different levels when it comes to diabetes prevention and management. So first is primordial prevention, where general population is targeted. And for prevention, yes, raising awareness is a good strategy. Primordial prevention can start with 1 generation before. That's the research from our unit again. Dr. Yajnik has shown that if you intervene in the mother, it's possible to prevent diabetes in the next generation. So it can start as early as that. But yes, even in adults, those who are non-diabetic, diabetes prevention is possible. Primary prevention can be in population at risk, and secondary and tertiary prevention can be prevention of complications and prevention of advancement of complications. And remission is also possible now in type 2. So I think putting goals into practice is important. So team approach, as I already said, very important. No one size fits all diet sheets. In many clinics, even now, just one plain diet sheet will be given to patients with diabetes, and not personalized counselings are provided. So I think that practice needs to be stopped, and best diet needs to be personalized. The best diet is the one which is easiest to follow on longer term. That has to be remembered. Short-term diets will not help. DCCT trial has also shown that individualized consultation with registered dietitian improved HbA1c levels in both type 1 and type 2 diabetes. So it's important to have one-to-one counselings and personalized sort of plan when it comes to diabetes management. So right now, there are many patients going to Google Guru and WhatsApp Guru. So I think it's better to come to a registered dietitian rather than going to such platforms. I know we have good influence of social media on all of us. So I think it's a responsibility of us as a registered dietitians and clinicians to produce a good content on web and have authentic information for our patients, where patients can generally follow to this guidelines and have good sources where they can refer to. And we are doing quite good at it. So at KEM and at Just for Hearts, we are having good amount of knowledge sharing experiences when it comes to type 2 diabetes as well as type 1 diabetes. And we have also developed an app called Madhuraksha to facilitate management of type 1 with calculators for carbohydrate counting. So such efforts will definitely help in a longer way. So finally, diabetes is easy to get, tricky to diagnose in early stages because of its asymptomatic nature, hard to accept, people won't accept it, difficult to manage if team approach is not followed and there is no patient education and patient involvement. But it will be definitely easy to manage if the entire team involves in the management. If patient is made well aware about diabetes management, its complications and repercussions, and if there are sustained efforts on longer term. Thank you so much.
Wonderful, Dr. Tejas. I have a very small question, then over to you, Dr. Rao. Can you just briefly tell us about this continuous glucose monitoring, which the one which you showed here?
Yes. So this is the kind of sensor we put. So it's called CGM, and the model now is called Freestyle Libre or Libre Pro. And there's a small sensor inside, and you can monitor your sugar levels either on the reader or a mobile app. And you see the trends in blood sugar levels. So it also gives statistics like estimated HbA1c levels and general trends like which meal needs to be improved when it comes to normalization of blood glucose values. So it's a great tool and you all must use it.
Yeah, there are few more models of CGMS.
Yes.
One is the Freestyle Libre, where you can't see directly it happening real time. There is one Medtronic, one the Dexcom, which is real time, and one pharma company recently has launched Aries. I don't remember their brand, but there you can in the app see the real time glucose rising, falling. I've not used it in a normal person. After a real time, throughout the day, you can see. So the app is there, and the device is there, and that device connects. It sends the data directly to the app. You can see it in your mobile, right? Live.
Yes. It's available online, and even your doctors can help you for that.
You can directly buy it from the distributors nowadays, which works out to be cheaper actually. And, many people are doing, patients are doing it by themselves, even without us recommend. I think this is the future. What she has said, we are moving from self-monitoring of glucose from glucometer to the real time. So, and in diabetes, as we see, that everything in diabetes is silent. The most common symptom of diabetes is no symptom. So monitoring, that's the way. And that helps you take right time, right decision. If you don't monitor, patients there is a lot of clinical inertia. Patient ultimately comes, the main reason for complications in diabetes is because it is silent and because right time, right decisions are not taken.
Surprisingly, some doctors say that no need to check your sugar level so many times.
That's
when we recommend patients that you eat and see what happens to your sugar, they will go to doctors, they will show the doctors, and doctors say, check karda tumi, not needed. Which is really...
I practically encourage my patients to monitor and many times take decisions on that.
Yes.
You just passively don't monitor and write it down. Take decisions, especially when I see GDM patients. Almost every few days we have to adjust the doses. So we encourage them, we just tell them about how the insulin, what duration of action, so how to adjust the doses yourself. So we need to move from monitoring to self-monitoring to self-adjustment. That also helps. So type
should
1
be
kids,
active kind of monitoring.
Type 1 and gestational diabetes,
Yes.
Yes. It's actually put in the interstitial. It's looking at the interstitial
fluid.
So some time lag will be there.
Around 15 minutes time lag.
Many of the CGMS have to be calibrated by your glucometer.
Yeah.
At least 2 readings per day.
Okay, thank you so much.
Thank you for a nice, very nice, and I think this is the need of the day. A lot of social media influence is there. A lot of our time as a clinician goes in explaining the patients that social media, the wrong influences that social media is giving. Just to clear that doubts, we are having a lot of our time is wasted. I personally feel a team approach is very important. I don't call send my patients to a dietitian. I send them to a nutritionist. So as madam said, a diet manje thoda negative connotation hai to, but when you talk about nutrition, it's more positive. So I always refer to my my patients as when I send them to anyone, it's nutritionist, not a dietitian. And the right information has to come. So it's a very good initiative from YouTube's and other things you have started. The right information has to, because I think as doctors, from day one we have been told not to advertise yourself, not to, but the other negative influences which is happening, they ye bindas येऊन काही बोलून जातात. We don't even go and defend. कशाला यांच्यामध्ये, why should we go and असं होतं. So I think right information has to go in. People have to have access to the right information. Then that makes a big impact. I think it's a good initiative. Thank you.
Thank you. Tejas, will you wait? It was a wonderful session by Dr. Tejas, a very simple and practical tips. And I think that's the right thing to do, the teamwork. And I think, yes, a lot of doctors and nutritionists should get onto social media to have the right knowledge spread across. So now I would like to felicitate Dr. Tejas Limay. And for that, can I have Dr. Meenakshi Deshpande come on stage to felicitate her? Thank you so much. Meenakshi ma'am, you could just wait for the next felicitation. Now we would like to felicitate Dr. C.R. Rao, and for that, Dr. Meenakshi Deshpande and Dr. Raju Varyani, he could just come on stage so that we could do the felicitation. Thank you so much. I think Dr. Suhas Arekar is pressed on time, so we would like to felicitate him. So I would like Dr. Raju to continue to be on stage. And also I would like to invite Dr. Kedar to come on stage, and also Dr. Alka Shirsagar. Can I have Dr. Geetanjali Sharma come on stage, please? Anybody more? Can we have all the faculties come on stage, please?
Dr. Sanjay Patil, our executive trustee, please come on the dais. Dr. Rajan Sancheti, Vice President, IMA Pune, please come on the dais. Dr. Padma Iyer, Madam, Past President and Treasurer, IMA Trust Board. Dr. Ananta Kulkarni, our Managing Committee member. One minute.
Thank you. Thank you, everybody.
Before we continue, just for Dr. Sato, he wants to talk about the next conference for 1 minute.
Yeah, sure.
So I'll invite Dr. Sato, President of Pune Pimpri Chinchwad Bhosri Association, for telling about the IDCon. So Dr. Sato, please come. Yes.
Good morning, everybody. President Dr. Meenakshi, Secretaries Dr. Alka and Dr. Geetanjali, my friends Dr. Sanjay, Dr. Raju. We are here from IMA Pimpri Chinchwad Bhosri branch. Our President Dr. Vijay Sato and myself, Dr. Sushil Muthian, President-elect. At the outset, a very good morning and sorry for the interruption. I'll be just taking 2 minutes. As you all might be aware, we are hosting IDCon 22 on 2nd and 3rd of July at Hotel Orchid, Balewadi. I request everyone to please register, as this is the largest branch and we have high expectations, and we all are organizing it since it's a inter-district conference. Few highlights: we have orations, 2 orations of one of Dr. Dilip Karnik, Advocate Dilip Karnik, second by Dr. Bhushan Shukla. We have a keynote address by Dr. Sanjay Oak, workshops on basic life and advanced life support and orthopedic trauma management. And last but not the least, a gala dinner on Saturday, full-fledged academic and social feast. So I request you all to please register. And I request President Madam Dr. Meenakshi to please motivate everyone. Thank you so much. And we await your presence at the conference. Thank you so much.
Actually, we had hosted this CAB in 2015, and this is our second time. And in last CME, we had more than 500 delegates. So we are expecting more support from IMA Pune. Yeah. And the early bird registration is up to 15th of June, that is 3,500. Thank you.
Last 6 MMC points.
We would start the next session. And for that, I would like to call upon Dr. Geeta to chair the next session. And Ms. Pooja Ladda. An introduction to Dr. Pooja Ladda. 12 years of experience in renowned hospitals like Wockhardt, Jahangir and Ruby. At present, HOD of Pune Hospital. Qualification is MSc Health Science Dietetics RD, member of Indian Dietetic Association, Indian Association of Parenteral and Enteral Nutrition. Special interest is bariatric nutrition and critical area nutrition. Yes, so we'd like to welcome both of them. And now I would like to call upon Dr. Raju Varyani to introduce the next speaker. Thank you.
The next speaker is today's hero of the CME, Dr. Kedar Patil. He is a renowned bariatric and advanced laparoscopic surgeon. He is lead surgeon, Precise Clinic, executive committee member, Maharashtra State Chapter of ASI, joint secretary of IMA Pune. His special academic achievements include publications in JMAS, IGS, obstetric surgery. He has presentations at various international conferences. He is faculty and examiner for the fellowship in minimal access surgery awarded by AMASI. I invite Dr. Kedar Patil on the dais.
It's always a pleasure to be introduced by such an enthusiastic personality of IMA, Dr. Varyani sir. Thanks for the introduction. First of all, thanks to IMA to take up to the idea that we should be doing a CME with the dietitians involved, because the problem that I mentioned you all, that there's a big gray area between doctors' advice, dietitians' prescription, patient's perception, and the whole circle. There are some lacuna which are there. So my talk is about bariatric surgery. So amongst those who are present in the crowd, I would like to have a hand show. How many of you can confidently say that they know about bariatric surgery? Okay, the reason I'm asking this, because the talk needs to be modified, whether I should be speaking more of the basics and then speak less about the nutrition, although the topic is more about nutrition. But unless we know what is bariatrics, we cannot go to the further step of what to advise in nutrition and supplements for bariatrics. So I think I forgot to mention IDA's role. We have been doing these CMEs for the last 5 years and trying to address the same problem of the lacuna in the prescriptions and the understanding of both the subjects. So my first half would be about bariatric surgery. Second half would be about nutrition and supplements. So when we are speaking about bariatric surgery, we need to understand, when we are speaking about bariatrics, it is about weight loss. When we are speaking about metabolic, it means that we are looking to treat the disease. The simple differentiation is someone coming to asking for weight loss, he qualifies directly for a bariatric surgery. Someone asking ki माझा diabetes bara होणार आहे का surgery नहीं, he qualifies for a metabolic surgery. So that's the intention to treat difference that we have when we are saying about bariatric and metabolic surgery. Surgeries may be same or different, but it's the intention to treat that when we term it as bariatric and metabolic. Simple formula that you can calculate in your OPD, the ideal weight is height in centimeters minus 100. All the dietitians, I'm sure they have these apps on the mobiles wherein you put in your height in meters and you put your weight in kgs and you get the BMI. So BMI is a very, very important aspect that we all need to know, because the whole concept of obesity management is based on BMI. One needs to be aware of this fact that pharmacotherapy can only help in weight loss to the tune of 5 to 10%, be it any drug on the world. There is enough evidence published today that someone who's coming with a weight of 150 kgs is not going to come to 80 with medicines. Let me make this very clear. He requires surgery. So there are definite indications where surgery has a role. There are definite indications where medicines have a role. There is a definite role where diet and exercise has a role. So if someone who's not losing weight for more than 3 months with medicines, either it needs to be changed, stopped, or added on. But one should not be prescribing more than 3 months if there is no weight loss. Again, an important slide of my presentation, bariatric surgery is for someone whose BMI is about 32.5 with diseases, 37.5 and above without diseases, because they will eventually have diseases in near future. So even if some patients come asking to us that I don't have any problem with my weight, I'm 120 kgs, why should I undergo surgery? The answer is this: there are 30% chances of a person developing type 2 diabetes, and the cumulative incidence of metabolic syndrome is more than 50% if person is overweight. For metabolic surgery, the criteria are different. As I told you, someone who's not well controlled with the best medical management, be it medicines, be it insulin, be it lifestyle changes, if someone is not being controlled, then the indication for metabolic surgery is 27.5. So these are the different indications for bariatric and metabolic surgery. Person who's not motivated, डॉक्टर मला फक्त ऑपरेशन पाहिजे, मला दुसरं काही नको आहे, मला जमणार नाही एक्सरसाइज, these are bad candidates. These should not be operated. They should be put on a 3 months trial with diet and exercise module, see if they comply, and only then they be offered surgery. Psychiatric illnesses, severe depression, schizophrenia, alcohol abuse, unmotivated person, as I mentioned, portal hypertension, and malignancy, organ failure, these are contraindications. So we again get calls from people saying that like my weight is 120 kgs and I have diabetes. Which surgery do you advise? Again, this is not a one-liner answer that I can answer to the patient straight away, although sleeve is the most common procedure done. But when we are advising bariatric surgery, we have to take into consideration age. For example, above 60 years, we cannot bypass, cannot advise a bypass because the compliance requirement for a bypass is much more. The multivitamin intake has to be regular. Old people cannot follow to what everything is advised. So less than 18 years of age, we generally do not operate. Bypass procedures avoided in young. So these are the things that we have to think into consideration, take into consideration when we are advising a particular surgery. BMI, again, someone who is more than 50, we have to think in terms of a bypass, not a restrictive procedure. Someone coming asking cure for a diabetes, again, we have to think about bypass because that is a more stronger surgery in terms of metabolic effects. GERD, quality of life, diet compliance, whether this person will follow the diet and exercise is also to be considered. Whether this is a sweet eater or a volume eater, again, makes a difference. A psychological factor, whether this person would come for a follow-up, someone who's in remote Chandrapur area, I cannot just operate a bypass to this person and leave him because I know he will land up in problems at maybe 5 years, 10 years down the line. He would not come for follow-up. So supplements intake, again, they have to spend a little amount every month on supplements. That also has to be taken into consideration. The setup and training, just doing sleeve is not enough. The bariatric surgeon should be doing all kind of surgeries according to the patient. It has to be a tailor-made surgery. And cost I have mentioned as the last factor that should never be a consideration unless the person is very much non-affording. Because that should not be a decisive factor for choosing the right surgery. This is a very simple score. All of you must be aware of this ABCD score for diabetic patients. It's age, BMI, C-peptide levels, fasting C-peptide levels, and duration of diabetes. If you have this with you, just by doing a C-peptide, you can tell the patient, type 2 diabetic patients particularly, whether their diabetes would improve with bariatric surgery or not. So a general recommendation is any diabetic who is less than 10 years newly diagnosed diabetic. Let me make it very clear to chairpersons and faculty that we are not asking all diabetics to undergo surgery, but poorly uncontrolled diabetes and a particular time when a diabetic person is being shifted over from an OHA to insulin. That is the time you should recommend this patient. You think about bariatric surgery. Again, one more important thing is of all the persons who come for consultation with us, only 7% get operated. This is a worldwide statistics. So one should not be fearing that this patient would be lost and he would not be coming back because only 7% undergo this surgery. So this consultation, when you're shifting from an OHA to insulin, there should be a recommendation to these patients. So bariatric surgery is something, what we are doing is we're reducing the size of the stomach. The ghrelin is secreted from the fundus. So we are removing the relation of food intake and ghrelin. So even if the person is eating less, he won't feel hungry. The second beauty of this procedure is antrum is preserved, intrinsic factor deficiency is less, B12 requirement supplementation or lifelong may not be required. Calcium, since the integrity of the gut is maintained, the deficiencies may not happen as would happen in an bypass. So this is the most popular surgery worldwide. 70% surgeries are sleeve gastrectomies. The technical simplicity, there are nuisances to it also, but it's more simplified compared to a bypass. So this is only contraindication would be a severe GERD and liver cirrhosis with portal hypertension. Of course, alcoholic patients, we need to be careful. But given a choice, we first think of a sleeve, then unless a person has comorbidities, and then think about a bypass. So this is also a first stage procedure in super obese patients where the BMI is more than 50. They are very high risk patients unless optimized. So these would be the classical indications for a sleeve. And there is something new, but most of you might not be knowing that there are some procedures known as sleeve plus procedures where we are combining a sleeve gastrectomy with a bypass. So this has come up in the last 3 years in a big way. The reason is there is something known as an foregut and hindgut hypothesis, which is proved in animal models, that if you transect the duodenum here, the anti-incretin signal reduces, the diabetes control happens early. So by doing a sleeve and doing a proximal bypass, if you notice the duodenum is transected here, the intestine is attached here. So this anti-incretin signal will go away. At the same time, the food is delivered to the distal small bowel early, thereby the GLP-1 level, PYY levels rise, thereby diabetes gets controlled. So this is the hindgut theory. So with sleeve plus procedures, we are giving both benefits, that we don't want malabsorption to happen in a big way, but we are giving more profound hormonal effect to the body. So this is how sleeve plus procedures work. I don't want to get into the technical details. There are about 8 to 10 different sleeve plus procedures. Then coming to the bypass, mini gastric bypass is done quite frequently in India. So what we are doing in a bypass is we are creating a small pouch and we are attaching the small intestine to this pouch so that the food goes into the small intestine early. There's a technical difference between a classical gastric bypass and a mini gastric bypass, that there's a small pouch we are creating and we are attaching the small intestine here. We are doing an enterostomy here. The bile, pancreatic juices, acid mixed with the food here. So we are creating a restriction and we are diverting food here, thereby reducing its absorption. For those who are patients between 27 to 32, they go in for these procedures where the patient has tried everything, including diet and exercises, and not lost weight. So an intragastric balloon is a good option in these patients, wherein they want to reduce about 10 to 15 kgs is what we see with the balloon, and they get back to the routine of maintaining it with diet and exercise. This completes the basics of bariatric and metabolic surgery, including the balloon, which is an option. Generally speaking, we do recommend diet and exercise as an first modality for patients with a BMI of 27 to 30. I would be elaborating this in the panel discussion. But to make things clear, in a clear perspective, 27 to 32 is a range zone where diet, exercise, balloon, liposuction comes into picture. But above 32, we have to think in terms of bariatric surgery unless contraindicated. So with bariatric surgery, a person requires lifelong commitment to following a proper diet, exercise, lifestyle changes. This is integral part of any bariatric surgery. It cannot happen just with surgery. Supplements, the main supplements that we provide are protein up to 1.5 gram per kg per day, B12, vitamin D, folic acid, zinc, iron, calcium. These are the major ingredients that we need to consider when we are advising supplements to these patients. Of course, they require the minor supplements in between, but this is something that they require on a regular basis. So just 3 case studies as to understand, because the dietitians also, those who are attending, those who are listening online, they need to understand why this surgery was done to this particular patient is very, very important, and just not see and treat these patients. They need to go get into the details why this particular surgery was offered to this patient. So I have just 3 cases in brief to discuss. So this is a gentleman who has BMI 54, he is 180 kgs. Not very well affording patient. He's having sleep apnea, abnormal eating habits, no exercise. So he requires a one-time solution to his obesity. So considering all this, his endoscopy is normal. There is no GERD. We have offered him MGB. Now it's been quite a long time. It's almost 3 years now. He's stabilized at around 90 kgs. He's lost 80 kgs. Those people who have more weight, they lose more weight. Those who are, overweight by 30, 40 kgs, they lose about 60 to 80% of the excess weight. This young female, 26, about to be married, she's tried everything, not able to lose weight, planning for a conception. So obviously I cannot it's been 3 years I've operated her now. 44 years female, BMI 37. She is having the classical metabolic syndrome. but on endoscopy, she is having GERD. So I have to think in terms of a bypass. So this is my quite early patient 5 years ago. She is doing extremely well. She's off diabetes and hypertensive medications. So this is an individualized surgery. Just doing sleeve to all patients is not the solution. We have to take into consideration many aspects. We have to take into consideration many aspects before advising a particular surgery. Support groups are a very much integral part of bariatric surgery, wherein these patients are taught what is right to eat, what is not right to eat, how to exercise, because they have some unique problems that you cannot understand unless these people open up. So support groups is a good way to get them together. It's a group therapy that we are doing, and a bariatric surgeon needs to have a support group. Just doing surgery and leaving these patients is not the right way to treat. Unfortunately, in our society, what we are seeing is surgery. त्या सर्जरीचे खूप साइड इफेक्ट्स आहेत. ती सर्जरी करू नका. त्या पेशंटचा प्रॉब्लेम होतो. Unfortunately, the success stories do not come out in the society. Only the complications are discussed. And due to the fear of this surgery, many patients get these therapy late in life. I mean, they have suffered from obesity all their life and they get treated in the end, which is a bad thing. So they need to be referred in the right place at right moment before obesity creeps in. The side effects of obesity creep in. The last aspect of my talk is about the nutrition supplements and the nutrition management. So this is a single most important slide for those who wish to understand nutrition after bariatric surgery. Is that the majority of the vitamins, calcium, iron absorption happens in the proximal gut. That is the duodenum and ileum. And gastric acid is an important factor wherein it helps in protein, carb, and fat digestion. So when we are bypassing these things, we need to supplement. That's the basic ideology, where you need to supplement more when you're doing a bypass and less when you're doing a sleeve. RD, I need not go into the details. Any textbook can give this. So what is more important to understand is, for bariatric patients, we need to give 150 to 200% of RDA. It's not just RDA. So someone who is having calcium, for example, we need to give 1500, not 1000. So we need to understand this, that the RDA requirements need to be more. We need to supplement more. So again, most of these patients have some subtle faulty eating habits. So time and again, most of our time is gone into this consultation and telling them that they need to eat slow. They need to separate the solids and liquids. They need to avoid concentrated fats and sugars because that would cause dumping. They need to have protein first, which would give them a good satiety effect. They have to, I mean, Geeta Madam also mentioned, or someone mentioned, that they have to see the food labels, what they are eating. They need to have good liquid intake, more than 2 liters. Fiber intake has to be adequate. So these are the general instructions, that water intake has to be good. They have to separate the solids and liquids. They should not be having water along with the food. 3 to 4 small meals. Then iron and calcium has to be separate. Vitamins in the morning, proteins before meals, calcium after food. And antacids with any other medicines are discouraged. So all these instructions need to be clearly informed to them. And sometimes they get intolerance to food. The most common what we are seeing is rice intolerance. That is a normal thing with sleeve gastrectomy. So they need to be informed beforehand that you would not be able to eat rice for probably first month after sleeve gastrectomy. If there is intolerance to a food, they need to avoid it for a few days, then reintroduce slowly. Then carbonated drinks, of course, they need to exercise. And since they are eating less, bowel movements would be irregular for the first year. They might go to the washroom once in 2 days. That's normal. We need to inform them. Many people come back saying that they are just eating half an chapati or 3/4 of a chapati and they're feeling weak. We are supplementing them. So again, this is a process that we need to inform them that that's the normal intake after bariatric surgery. The reason you are feeling weak is it's in the mind. We are already supplementing you since you are eating less. So all these things need to be explained to the patient in a proper way. They need to have a diet chart, and we need to also have a weight recording or monitoring for these patients, because too much of weight loss in a short span or too less weight loss over a long time is bad. So we also need to keep a monitor at what point of time, at 3 months, how much weight they have lost, 6 months, how much they have lost. So pre-op, I haven't touched much because there's not much to speak in pre-op dietary management. It's 7 to 15 days of pure liquid diet, wherein all liquids are allowed except the high carbohydrate drinks. Salads are allowed. The idea is to have weight loss about 2 to 3 kgs. Liver becomes easy to manipulate because when we are operating, we go below the liver and we operate. So that is the reason we put them on a pre-op liquid diet. It also helps to reduce the carbohydrate intake. Weight loss happens, the anesthesia risk reduces. Post-operatively, for the first 7 days, they are on liquid diet. 15 days, they are pureed diet. Pureed means something in plain simple Marathi is चपाती वरण कुच करून द्या. जे काही देताय लहान मुलाला दात नसतात तेव्हा जे आपण अन्न देतो, that is pureed diet. Very simple to explain to patient. They will understand this. If you go by the charts, it's difficult to understand. So whatever a kid who doesn't have teeth, whatever you are feeding him, just feed the same thing to the person, he can eat it well. And a regular diet is after 1 to 2 months, depending on the type of surgery that we are advising. And after that, they can have normal homemade cooked food. There is nothing different that we need to do to these patients. Again, this is a sample prototype. You can have your own. We need to explain them what is rich in iron, because there are a lot of food fads and food myths to these patients as well. Like for an example, one patient of mine was eating cheese and she's not losing weight. When I went to details, I got to know she's eating cheese. I asked her what was the reason she's having cheese. So she had read somewhere that cottage cheese is allowed. Cottage cheese is paneer. It is higher in protein. So all these things, you need to explain them what is good for iron, what is good for calcium, B12, folic acid, vitamin D. And this is the 1 year period that we get, we call this as a honeymoon period after bariatric surgery. Because even if they won't do anything, they're going to lose weight. But that is the time frame when they need to adjust their food habits, their food exercise regularity has to come in, so that they maintain this lost weight. So support group meetings, we are time and again encouraging them, making them understand what is good for them, what is bad for them. So prototype of caloric chart, again converting एक चमचा तूप म्हणजे किती हे नॉर्मल माणसांना माहित नसतं. So give them charts, explain them 1 teaspoon sugar is 20 calories. One normal Indian diet meal would be 500 to 800 calories or more, depending on what you're eating. So converting the caloric chart and explaining to the patient in plain simple language is very, very important. And therein where comes role of a dietitian. So again, prototype of exercise chart, make them understand jogging for 45 minutes. When we ask, most of them say, I do yoga. But let me tell, yoga is not for weight loss. Yoga is for flexibility. If you want to have a weight loss, one needs to have aerobic exercise. Weight training can also help in weight loss. So these small, simple things, if you make them understand, they can change the lifestyle and improve on the weight loss. So just a brief account of the essential nutrient deficiency is protein. They can have fatigue, hair loss, muscle weakness. These are the investigations that you need to order. Just doing serum albumin levels is not helpful, because pre-albumin, transferrin and transthyretin have much more shorter lives. Iron, ferritin, serum iron, TIBC, transferrin, ferritin. So folate, for folic acid, we need RBC folate. Serum folate levels are very poor markers. Vitamin D, alkaline phosphatase, parathyroid hormone, 24-hour urinary calcium. These are the investigations. It may not reflect in serum hydroxyvitamin D levels. B12, we need to see the urine. Serum may not be, sometimes it is masked. So if you are suspecting it strongly, you also need to have urinary MMA and homocysteine levels. So I mean, there is a big list of things that is to be avoided. We all know this: fried food and bakery items and all. These some of the patients can have fat malabsorption, wherein they can have diarrhea, steatorrhea, or flatulence. This is the investigation: fecal fat more than 7 grams per day. You just need some dietary modifications for it. Sometimes pancreatic enzymes can also help. Carbohydrate malabsorption, they can have flatulence, milk intolerance, diarrhea. These are the investigations: acidic pH stool, hydrogen breath test. For protein, then they'll have edema, growth impairment, poor immune response. And these are the investigations that are required. So let me tell you, only 10% of patients have these nutrient deficiencies in the long run. It is entirely up to the patient, the doctor, and the team as to how much they would follow, these patients would follow up. So follow-up is again a very important factor. The dietitian needs to have close monitoring over these patients over long term. So what we are following in our clinic is, after 1 year, patient gets a free follow-up, whatever number of times patient wants to come. The reason is we want to lose them, have them weight loss in a healthier way, and just not have weight loss. So that's the reason we are following this policy. Sometimes they can have vomiting with food intolerance, or sometimes if it is persistent for a long time, we need to relook with sometimes with an barium or gastrographic studies or a CT scan. But mostly it is due to faulty dietary habits. Asking them to eat less slowly makes a big difference. Constipation.
5 more minutes.
Yeah, I'm just last 2-3 slides. Constipation, again, it's perceptive. There is nothing that would go wrong in the abdomen to cause constipation. Since they are eating less, they would feel constipated. So again, making them understand that it's okay to have stools once in 2 or 3 days. Giddiness is a common complaint in the early post-op period, because they would not drink water. Water is again something that we have seen that they have some different taste in the initial period. So asking them to have flavored water helps. Dumping is something that there are 2 types. There is early and late dumping. Early is when high carbohydrate rich food goes into the intestine. It draws fluid from the body. There is hypotension, person feels giddy. Late dumping is due to the sugars shooting up, drawing fluid, and the BP getting low. So asking them to changing their food habits, eating slowly, avoiding these high concentrated fluids. Then we need to also inform, sometimes they have some taste change and smell change. That may be due to micronutrient deficiency, but it is a phenomenon that is seen commonly in about 20-30% patients. So you need not get worried about it. And deficiency, as I mentioned, only 10% would have it in the long run. If they follow what has been advised to them, there is nothing that can go wrong. So we do have a channel which has 27,000 subscribers. All these patient educational videos, all that I'm speaking, it's there. We've tried to make it, less cluttered with medical information for patients. And there's a lot of information available on this channel that these patients can go through. And I'm sure with a good team, these patients can definitely be benefited to the maximum. I thank IMA Pune, IMA CGP, IDA Pune for getting associated to this program. Our office bearers of IMA Pune, Managing Committee of IMA Pune. And of course, any program is successful only with delegates. Let me tell you, we have about 270 online people attending and about 50 to 60 physical registered delegates. Thank you all.
Thank you, Dr. Kedar. Such a big topic you've concisely summarized in 35 minutes or 30 minutes. One question which I have in mind is, you did mention when you asked about procedures that there's a restrictive surgery, there's a malabsorptive surgery, but there's also an intraballoon gastroscopy. Any inputs in that? Because that's not an interventional surgery. So
you mean to say intragastric
balloon?
Balloon is not in surgery. We don't consider
Exactly.
it as surgery.
So how about making a weight loss therapy with that? Because end of the day, it is restrictive format of eating.
Yeah. See, endoscopic two therapies are in vogue. One is balloon and second is endoscopic sleeve gastroplasty. I'm sure you must have heard of it. So balloon is something, it's a silicon material, chemically inert thing, wherein about 500 to 700, up to 1 liter also fluid can be installed in the balloon. So this balloon floats on the food and water that we are eating in the fundic region. So it abates the fundus and ghrelin levels do not increase. The person, because of the weight as well as it getting abated in the fundus, the ghrelin levels remain low. He doesn't feel full. But this is only useful for a typical patient. I would say someone who is about to get married, young motivated females or young motivated males as well. Those who have tried, done diet, exercise and have failed. So these are good candidates for balloon, and the BMI range is 27 to 32. So the volume intake reduces and that is how they lose weight. But on the flip side, once we remove the balloon, they can have an weight regain. So we need to inform them that you have tried everything, you have failed. This is a means to achieve and target, but maintaining that target again is entirely up to the candidate. The second procedure, endoscopic sleeve gastroplasty, to be honest, although it is marketed as a non-surgical procedure, it is a surgery because through endoscope, we are stitching up the stomach from inside, which previously used to do with laparoscope. Plication, gastric plication was a surgery that was done in previously. But again, the subset of patients for these procedures would be different. Those who want to lose about 10-15 kgs, those who want to get, typical would be TKR patients, or those who don't want scars on the abdomen, those who want to have it simple. So these would be the patients. Malabsorption with plication would definitely be less than these procedures. So, I mean, all the procedures have definite role. There is nothing like I'm doing only sleeves, I'm only doing bypasses, I'm only advising balloons, I'm only advising diet and exercise. There is nothing like that. All the places in treatment have a definite role and we need to follow that.
So how long will the balloon be?
There are two types of balloons. There are non-adjustable balloons, there are adjustable balloons. Non-adjustable balloons, once filled, we cannot alter the volume. We generally don't prefer them because if the patient doesn't tolerate it, we don't have any option. We have to just remove it. But with an adjustable balloon, if the person has, intolerance, we can reduce the volume of the input that you have put in the balloon. So generally what we prefer are the adjustable balloons, which can be kept up to 1 year. Non-adjustable only 6 months.
Thank you. Any questions from the audience?
There are patients, those who would be in that middle range without diseases. So as I mentioned, if they are above 32.5 without comorbidities, we need not advise them surgery. But if they are about 37.5, they require surgery. 32.5 and above with comorbidities, they definitely require surgery. I mean, you can always advise whether to do it or not to do is entirely up to the person. It's up to 15 to 18% in sweet eaters. So one of the points that I mentioned in patient choosing a procedure. So if someone is a sweet eater particularly, we have to think in a different terms that this person needs more motivation or we need a different kind of surgery for him. And as I said, it's never only surgery. All things have to be there together. So to be precise, it is 15 to 18% of those who are sweet eaters. Pediatrics, we don't advise surgery unless person is 18. Yeah. So right now also we do have a doctor who is under treatment with us, but I've not gone for surgery immediately. Where you feel that these persons are not motivated, you need to let them earn the surgery. That is important. They need to, at least for 3 months, be under diet, exercise and psychological supervision. You make sure that they are doing this, because then you would ensure that this person is going to follow what has been advised later on. Liposuction is a different entity. So I'm sure Dr. Kulkarni is here. He's a plastic surgeon, but 27 to 32 or anything about 25 can be advised liposuction. It's a cosmetic surgery. It is for beautification. Bariatric surgery may add beauty to a person, but indications of liposuction and bariatric surgery are totally different. Yes.
Thank you, sir, for the wonderful presentation. In simple words, you explained the complex management of bariatric surgery and nutrition. As sir mentioned, to understand the bariatric nutrition, it's important to understand bariatric surgery. This message for our dietitians too, because according to type of surgery, dietary management varies. Means you can understand the deficiency. In sleeve gastrectomy, the micronutrients deficiencies are less, whereas there is problem like dumping syndrome is more common. And when there is bypass, we can see the most of micronutrient deficiencies. So for dietitians, it's necessary to understand at least basics of bariatric surgery. That's all. Thank you, sir, and thank you, audience.
Thank you.
Thank you, Dr. Kedar. It was a wonderful session and really insightful. I think we got to know a little more about bariatric, more details about it. Now, I would like to call upon Dr. Meenakshi Deshpande to felicitate Dr. Kedar Patil. Can I have Dr. Raju Varyani also? परत आहे ना. Thank you so much. Ma'am, you could wait up. We could do the next felicitation. Yeah. Can I have Pooja Ladda Nyati for the felicitation? Mrs. Shilpa, will you come to do the felicitation? Can I have Dr. Geeta too? She was there in the chairperson. Thank you so much.
One more from us because after the talk, you are a chairperson.
Thank you so much. We'll take about 2 minutes for the arrangement of the panel discussions.
पेपर लावा पीपीटी पण पाहिजे पीपीटी पण इकडे एक लावा तिकडे दोन लावा 9 जण आहेत
Let's have a panel discussion now. I would like to call upon Ms. Shilpa Shirore to be the moderator. An introduction to Madam. She's a registered dietitian and consulting nutritionist with over 25 years of experience. She's a certified diabetic educator, a certified nutrigenomic counselor by Gene Support, convener, Indian Dietetic Association Pune chapter, consulting dietitian to DORH program at Pune Hospital and Research Center, faculty, Master in Physical Education, Savitribai Phule University, and DS Nursing College. Madam, we would like to have you over. I would now like to invite the panelists for the discussion. Dr. C.R. Rao, Dr. Pawan Hanchale, Dr. Sunil Zawre, Dr. Meenakshi Deshpande, Dr. Mahesh Thomre, Mrs. Anjali Kerkar, Dr. Geeta Dharmati, and Mrs. Ambika Nair. Just a brief introduction about Mrs. Anjali Kerkar. She's a clinical nutritionist, registered dietitian and consultant, Dinanath Mangeshkar Hospital. Her educational qualifications are she's an MSc and a gold medalist, recognized for conducting RD internship in National Institute of Nutrition, India. Expertise is critical care nutrition, metabolic disorders, which is diabetes, gestational diseases, PCOD, etc. She's having a rich experience, and we are happy to have you here, madam. Thank you so much.
Dr. Thomre sir is an MCH GI surgeon. He is one of the teachers for us, an eminent surgeon at Pune Hospital and DY Patil Medical College. And he has a lot of publications nationally and internationally at various forums and journals. Welcome you, sir.
Okay, good afternoon, everyone. Geeta, you need to come on. Yeah. So after an excellent academic session so far, we've put this panel discussion. So there are certain practical questions that come to our mind. We've tried to collate all the questions here so that, it'll help you understand the management as well. Now, this is a first scenario wherein there's a male patient who's coming to a clinic. His height is around 170 centimeters, weight is 90 kgs, BMI is 32. Lifestyle is sedentary. Now, my first question goes to Dr. Patil. What would be your approach or the treatment modality that you would consider?
Yeah, as I mentioned in my talk, so 32 BMI is a patient who can go always. He can go to diet and exercise, he can go to a balloon, he can go to a surgery as well. So for this particular situation, I need to know a few more details about this person. So whether this person has diabetes, has comorbidities, how much exercise is this person doing, already having a sedentary lifestyle. So this would not be a good person to advise surgery. Of course, if he doesn't have any comorbidities, he is not into a category of bariatric surgery. So this person at the first go should go for diet and exercise module. So at our clinic, we also have this 4 sessions module wherein we advise them dietitian follow-up every weekly, a physiotherapist advising about exercise weekly. Then we put these patients on 2 follow-ups with me as well. So I understand what is going well, what is not going well. A psychologist, if at all there are some issues with understanding of food or some stresses. And of course, we also require their lifestyle changes to happen. So if this person continues to do well, we would continue with the same treatment and put him on maintenance. If at all in second stage after 15 days, I may add some weight loss medicines with a clear understanding that he's going to lose about 3 to 4 kgs with medicines, not more. So what we assure or probably say to them is that they would lose 10% of their weight with diet, exercise, plus or minus medicines, not more than that. And if he has comorbidities, of course, he would go to a surgery. So this would be my approach.
Okay. Dr. Pawan, in the same case, let's say he comes with certain elevated LFTs. What would be the approach then?
Okay. So if this patient is obviously BMI 32, he is obesity. If now, as Dr. Kedar has already told you, we need to find out whether he has any comorbidities or he doesn't have any comorbidities. Okay. So change in the LFTs, derangement of LFTs has a lot of other implications. What is the reason for change in LFTs? What we need to find out. First, obesity, yes, that is one of the reasons which is in front of our eyes. What are other hidden factors we need to find out? So we have to screen these patients for hepatitis. So we do screen for all the patients for hepatitis B and hepatitis C. That is a universal screening we have to do. We have to do we have to take history of alcohol again. This initial talks, I think few speakers told about amount of alcohol and NAFLD versus alcohol related fatty liver. The fatty livers can be because of both of them. So if the alcohol intake is more, significantly more, that is more than 20 grams or 30 grams, we generally calculate alcohol in the grams. So this is what we need to find out. And then if these two factors are there, I would do a fibroscan or elastography to find out how the liver is. If the liver is a fibrotic or liver is non-fibrotic. And accordingly, then if metabolic syndrome is fulfilled, there are no other autoimmune parameters. We also do screen for patients for autoimmune markers like ANA, asthma antibodies, IgG levels. If everything is negative, metabolic syndrome is present, obesity is present, then this is likely to be a NASH. Okay. If there is a confusion, if we get two parameters positive, there are two etiological factors, then comes the role of the biopsy here to find out which is predominant one. So this is the way I would approach a patient of deranged liver functions with obesity.
Okay, thank you. Thank you. Now let's assume that this person doesn't go to any medical practitioner and is coming to a dietitian's clinic straight away. In that case, Anjali, what would be your approach? How would you go about the assessment?
My approach is very simple, very practical. When I go through the height, weight, BMI, and sedentary lifestyle, of course, the age is not mentioned. If any biochemical reports are there, it's not mentioned, but still, I go with the nutritional assessment, dietary history, and 24-hour recall sheet is the whole Kundli in front of me. With that approach, we advise him basically what is your at risk, and it is first contributory effect is or the problem is your diet. So he should understand properly where he is going wrong, how much really calories he is eating more, because he is sedentary, he is having the BMI at 32. So definitely he is more than the required calories. Maybe it is through the fat, or maybe sometime it is through the proteins. Yeah. So we have to balance out the thing, and finally he understand if you are having the counseling session for maybe 30 minutes or so, they understand, they realize, and they do it. Because with my long-standing experience of 33 years, I'm lucky enough with my maybe the age and the gray hair, they definitely follow. And I definitely say he will reduce 10 to 15 kg within a 6 to 8 months. And if even though he is having a metabolic syndrome or X or insulin resistance, definitely improve.
Okay. Dr. Geeta, any cases, wherein, I mean, not this particular case, but as a nutritionist, do you feel that your patient or client requires a bariatric surgery? I mean, how do you understand whether, you send him to a doctor?
So I pick up the same question and take it from there. Patient doesn't go to any medical expert. Wait, so he feels dietitian will help him. Step one, we know that he's been in positive energy balance, and that's why he's gained weight. history of how much weight gain in 3 months is very important for us to understand that what behavior management we need to work on. Give him some time. Definitely, I would screen the patient because with such a BMI, obesity grade 1 he's in, screen for liver function test, screen for renal function test, screen for his diabetes, insulin resistance, and understand the symptoms. Once you screen it, require medical support. If not required, continue with the diet management. Behavior modification, I think we need to give a timeline. End of the day, the weight management is all about mindful eating and eating. So first 10% at least for obesity grade 1, it's not the last 5-10 kgs. He needs to just knock off around 20-25 kgs. So there the behavior modification. Once the behavior modification doesn't work, there's no willpower, there's no follow-ups, then maybe as a placebo, we try to tell them, why don't you visit a bariatric surgeon? End of the day, weight loss is an answer for the health. And weight loss needs some kind of some therapy, some placebo effects, some medical management. And then let's see how the patient responds to it. But give some time for behavior management because that needs some kind of a counseling, hand-holding, motivation. And every dietitian is a different way. Like Sir said, every week you call the patient. Somebody do telephonic, somebody do virtually. So
okay, thank you. When we are talking about dietary assessment, there are many body composition machines which are available. Probably few of them are not that, economical for every nutritionist to have. So Ambika, I would like to ask you, are there any other anthropometric measurements which we can, consider, which will be helpful in the assessment apart from only a mechanical or entire body assessment?
Yeah, so in assessment criteria, when we generally assess the patient, it's not just your, anthropometric. It's like A, B, C, D, like anthropometric, biochemical, clinical, and dietary assessment. So in anthropometric, whatever you're asking is like about the body composition analysis monitor. So if that is not available, that's the best to find out because we are able to get a lot of parameters. Nowadays, a lot of machines are available with more than 22 parameters. So with the segmental fat. In case if that is not available, the best, is the waist circumference. There are a lot of research studies which have shown that your visceral fat is directly related to your waist circumference. So we can do the measurement of waist circumference, definitely a digital weighing scale, stadiometer, your height, weight. So you can calculate the BMI. And waist circumference cutoffs, like earlier it used to be like for men it was 90 centimeters, now it's 94, and for women it is 80. So we could use that as a primary criteria, because the visceral fat is not going to change immediately. There will be a lot of time. It will take a month or so for that number to decrease in your BCA. But your waist circumference, you can see immediate results. And, if they're following very well, it gives a good motivation for the patients. Okay. The inches loss, especially.
Okay.
The waist below 80 centimeters in women, below 90 centimeters in men. This is the first test we do in my clinic. Every patient has to do this and come. I myself check my waist every week and try to keep it below 90. That's the best way to prevent your diabetes.
He is one of our fitness motivator in our group.
So this is the most important. The central obesity, visceral fat, is the one which is the biggest cause for diabetes in India. And you can see even kids are getting centrally obese. You stand in front of a school, you see, I've done a COP study, that is child obesity program in schools. We found at least 5th standard to 7th standard students were checked. At least 30-45% of the kids were 90 and 80 centimeters, adult levels at that age. These are the candidates for future diabetes. So that is the problem. So the prevention shouldn't begin at 40 years of age. It begins as KM diabetes unit is doing, maybe at the maternal stage, the intrauterine stage, and much earlier. First, there is a paper, Small at Birth, Big at 8, published by Dr. Yasnik. That first 8 years determines the trajectory of your fat deposition. And about the BMI also, I just wanted to clarify. The cutoffs for BMI that we take, 25, 30, these are Western guidelines. Indian cutoffs are different. It is 23 and less is normal. 23 to 27 overweight and more than 27 is obese. So we are more, or rather we'll say we are less BMI sensitive. We tolerate a lesser degree of BMI to become diabetic. So that's a big difference. We have less muscle and more fat. Even a thin person like me, I would be adipose. I'm not obese, but I'd be adipose. I have 2 times more fat percentage for the same BMI Western person. So and studies also found the muscle mass in Indians is less. Indian men muscle mass is equal to Western women muscle mass. That's the difference. So a lot of new things are coming, a lot of gray areas. These cutoffs are all our cutoffs, and these have changed over a period of time. The fasting sugar was 140 when I passed out. Now it is fasting, we say 126, and then still there is a pre-diabetes stage, 100 to 126, which talks about so whenever I see any sugar, I'm seeing their pancreas actually. I'm trying to judge their beta cell function. So 50% of beta cells are gone roughly when you are in pre-diabetes stage. So all these are important when you talk about prevention, and I think diet, lifestyle management plays a huge role. But as doctors, we need to be an example of following what we are preaching. Most of my conference where I go for my talks, I carry my measuring tape, and believe me, less than 10% would be in the central or less within the 90 centimeters guidelines. So we need to practice what we are preaching. So a simple estimate will be the more part of the rib and the uppermost part of the hip in between. If you take that center of that, many people take the umbilicus, but that will be it will be changing the position. But the midpoint of the lower part of the rib and the is here. Yeah, and I do, but see, the pediatric age is evolving, so you don't have a fixed criteria of 90 centimeters.
Percentile is
BMI is there, but BMI for age is taken. In
BMI picture percentile. They have the growth
charts. BMI for age, the percentile is booked. Yeah. Ultimately, we take the percentile.
Sir, actually, what I feel is even making people aware. Like having more programs in schools, because we still are in that, khate pete ghar ka beta hai. They don't want to say that their child is overweight.
When I went to schools,
he's healthy.
When I went to schools to take permissions, I was not given permissions. And I found talking to the parents was difficult. To tell their parents your child is getting obese, they take it negatively. So a lot of concepts, so we have to be very diplomatic. You can't, it's not so easy to prevent. So things have to change from at very different levels. We're talking about the fat percentage assessment. Bioimpedance is what is done of the gyms, and that's not a very accurate marker of the best gold standard is DEXA scan, then deuterium water, but that's very cumbersome. So now DEXA scan is the gold standard for body fat, but the simplest and the best I feel is central waist, simple measuring tape.
Those who are, just to add to what you're saying, I won't take much of time. We have a lot of questions to discuss. Even this question I'm going to cut short. But everyone who wants to practice weight loss at least need to have a basic BCA machine of a good company. We don't have sponsors, but Tanita is a good company wherein you have range of 20,000, 25,000, 1.5 lakhs, 3.5 lakhs, and there are, higher end machines also. That is required because you have to tell patient objectively that you're losing fat, you're not losing muscle. So that alleviates the fear that mala weak vatte, mala khata yet nahi hai. So this becomes a reference point. You do it before surgery, you do for follow-ups also. It's not very costly investment. So all those who want to practice weight loss, I think they need to have some kind of body composition analyzer. Of course, DEXA is the best, but at least have a basic standard equipment for your patients to show the results.
Now, this is a case for Dr. Patil. This is a 43-year-old male, 180 is his weight, BMI is 60. He is suffering from sleep apnea, GERD. Incidentally, his blood sugar level is 350 milligrams. Now, sir, what would be the preparation for surgery, and what kind of surgery would you?
Again, I won't take long because we have other questions, but this is an actual case that has landed to me from UK. This person has come. He wants surgery in 2 weeks and go back to rejoin his work. It's very tempting to operate this patient, but the message that I want to give out with this discussion is bariatric surgery is not an emergency surgery. These patients have to be prepared well. if you have noticed, he's 180 kgs, his BMI is 60. He's in super obese category. His sugars are pretty high. He has GERD. He has bad eating habits. Also, he has sleep apnea, which is more dangerous, and we have to be careful about it. So super obese patients, we need to put them on LC, that is low caloric diet, probably some days of diuretics at the end just before surgery. The sleep apnea requires at least 3 weeks of CPAP to be used after a sleep study, assessing his AHI index. Sugars need to be controlled with the insulin because that would give a more predictable and better response. He needs to meet me every week before I operate him 3 weeks down the line to make him understand that it is not only about surgery. You would not be coming for follow-up for next 1 year, I know, because you're in UK. But you need to have at least a telephonic follow-up with me every monthly. So only if all these criteria are fulfilled, then only I would go in for a surgery, and probably a bypass is what I would be doing him with his food habits and his BMI. Thank you.
Now the next question. There are many fad diets. We hear about intermittent fasting. We hear about keto. There's always a shift between Devekar and Dikshit. So among all this, Geeta, I would like to ask you, what would you say about a keto diet? Does it really help? Because we know keto helps in epilepsy. Now, what about weight loss? Does it really help?
Diet in weight loss is all about eating less. Hypocaloric diet gives you weight loss, simple. Your requirement is 1800, I give you a 1500 calorie, it's easy. But that's not so mechanical. It's not 1 + 1 2 in each of us. We have our own challenges, satiety, snacking, socialization, inactivity. Metabolism becomes a major challenge. The diet pattern which makes you more disciplined and eat less works best, and people get result, and that is how it is promoted. Atkins was a very primitive diet where it was promoted that yes, eating a good protein in the diet has worked. End of the day, we've learned in a nutrition pyramid that carbohydrates have to be 40–50%. We've changed the way the carbohydrates, half the plate is vegetable, then the proteins and the fat. I think this is how the scientific approach of every nutrient which you need in the body from nutrition point of view. Keto diet is short-term goal, 2-meal pattern, intermittent fasting is a time-restricted diet. If actual intermittent fasting has a science behind it, and yes, we know that body uses fat as a source of, because at the end of the day, you're looking at fat loss. Keto diets make you eat less because of fat, which is having a delayed gastric emptying, proteins which give you a higher thermic effect. You end up eating less. I mean, we all say that egg biryani, you can eat 1 bowl, but if you have 1 bowl of dal, you can't eat so much, even in vegetarian source also. So protein fat consumption automatically is less, calorie control is better, appetite is controlled. And that's how I look at keto diet, that this keto diet helps you to feel early satiety, doesn't give you hunger pang because of the delayed gastric emptying. But I think it's not a sustainable answer. And plus, you would be having a lot of pro-inflammatory response through the diet because you add a lot of saturated fat in it. Your vegetables are zero. That's not the way we should be advising. So yes, epilepsy diet for a child with that weight is absolutely fine. You're looking at a 5, 8, 9, 10 kg weight. You're handling a male or female with 90, 80 kgs and you give a keto diet with almost 40% contributing of fat, with saturated fat, which we are actually looking at. No, I think that's not an answer for weight loss.
Okay. Dr. Rao, in case a diabetic wants to lose weight, are these fat, either a keto or intermittent? What does your say for a person who wants to lose weight?
Initially, I used to outright reject them. But then patients always want immediate response, immediate effects. So I always say now my approach is you try different things, whatever you want to, but you can't sustain this, or if you sustain this for long term, okay, but most of the patients can't sustain this for long term. The best approach is a balanced approach, individualized approach, which you can do for next 10 years, 20 years down the line. I always ask them, do you think you can do this for next 10 years? Then you can follow that. When you are doing any diet, say, if you obstruct your patients, they will go somewhere else. So rather than that, I said, whatever you do, you just keep monitoring your sugars, because suppose they do intermittent fasting and my medications are long acting medications, many times 12 hours, 14 hours. So they might go into hypoglycemia. So I have to at least warn them about hypoglycemia. I tell them the fat diets, you should lose, whatever diet you do, you lose only fat, don't lose lean mass. So try to go to a good diet nutritionist and maybe work out with her. But many patients do this, ultimately they can't sustain and they come back to us. This is my observation. Most of them come back to us and start following the normal guidelines.
Okay, any side effects associated with keto diet?
I think in some of my patients, I have seen very high lipid rise in cholesterol, LDL levels, very high. This is one. So it might increase the risk of heart disease. This.
Yeah.
Don't advise keto diets for the patient, especially NASH patients who so weight loss and liver has or liver diseases have different thinking altogether. We generally do not advise to go on a weight loss when the patient has a advanced fibrosis or cirrhosis. That is one message we have to give. The more weight loss you do, because they are actually losing more proteins than weight. That is a difference in liver disease and rest of the obesity. Only fatty livers and obesity, not having liver disease as such, means no NASH or no fibrosis, yes, they can follow whatever advice is required. But dyslipidemia is a problem. And yes, because these are the patients who are associated, the mortality in a patient with fatty livers is because of the cardiovascular. It's not liver which is failing initially. So that is what is important.
Okay. Meenakshi ma'am, I've heard that there was a study done on intermittent fasting among doctors. I would like to ask you, were there any consequences that were seen or any side effects associated with that kind of a lifestyle?
Yeah. I'd like to first, an interesting observation I would like to tell you all, because just now Dr. Kedar Patil told us that post-bariatric surgery, they call it a honeymoon period for 1 year. So now it flashed my mind why the patients will get pregnant immediately after bariatric surgery, because we tell them contraception for 1 year. You know, we understand that after bariatric surgery, all the nutrients have to get adjusted amongst each other before they can really go for conception. So this is an interesting observation, and thank you for that, because now I'll be able to emphasize more on that contraception part after the bariatric surgery, especially for adolescents when we do it for infertility. That is the first important observation which I wanted to tell. Second thing, yes, intermittent fasting we have done it in February and March 2019. There are 5 methods of intermittent fasting, and that time we had discussed amongst ourselves which method to utilize for our study. And most of us over here, whoever my year was there, Dr. Rajat Sancheti, Dr. Raju Varani, all and many, I think 25 to 50 people had actually come for the primary meeting. Later on, 30 to 35 of us really did the intermittent fasting part. We did it in a matter of 16 hours of fasting and 8 hours window. So that was what we found all convenient, because it was a thing which we could do during our practice. I mean, we could have just, and glad to say that I'm still continuing with it. I don't eat anything till 3 p.m. or 2 p.m. at least since morning. So that becomes about 15 to 16 hours of fasting. I just have a cup of green tea in the morning or 2 cups of green tea and hot water. There are cheat days, but many of the times in 1 month, I do it at least for 20 days. So that can give you a loss of, it may not give you a loss of weight, but it doesn't give you a weight gain. Second thing what we have observed is many people after study of 3 to 4 months, because we started it in 25th of, I think we started in February or March 2019, and the corona came. So we couldn't assess the blood sugars and the lipid metabolism or the lipid profile after 6 months, which we were going to do. But then many of the participants told us on our group that they had lost more than 5 or 6 kgs during that 3 to 4 months. So that was a very good response which we got from the intermittent fasting program of IMA Pune. And I can quote the names also, because I still remember that these people, especially Dr. Meenakshi Bagli, Dr. Bhageshri Gopte, and many more who told more than 6 to 8 kgs of weight they lost in the 5 to 6 months period after intermittent fasting. Okay. And many of them are still continuing. There are 5 methods of intermittent fasting, I think, and most of us adopted to this method, because alternate day fasting or fasting for just 2 days in 1 week or going for a warrior diet, that was not recommended for a doctor, practicing doctor. So we took up
Ma'am,
this.
and what about muscle loss? Was there any muscle loss associated? Because there's a myth that if you are on intermittent fasting, there is going to be muscle which is also going to be used up.
No, I don't think nobody lost muscle. It was all a fat loss. I told you we couldn't assess exactly the lipid profile, but most of them have found it very fresh and energetic feeling after having done this intermittent fasting.
Okay. Now coming to the next question, Ambika, could you just sum up very quickly, especially the macronutrient composition in case there is a weight loss patient? How would you go about it?
Yeah. So the balanced approach is first is calorie deficit. So whatever be the present intake, we calculate the calories of whatever the patient is consuming presently, and then go on start with a 500 calorie reduction per day. And we aim to achieve, so the safe way is do not promise too much, do not go to the idealistic weight loss, go to the realistic weight loss. So which can be like, you can promise probably around 5 kgs in 2 months, or half a kilo a week is what we can start with. But some of them achieve definitely 1 kilo a week also with good exercise and diet control. Now, as far as the macronutrients are concerned, carbohydrate, protein, fat ratio, the balanced meal plan, which is about 50 to 55% carbohydrate, consisting of more of complex carbohydrates and restricting simple carbs. Proteins, like how Geeta had mentioned, high biological value proteins, so around 15 to 20. So if it is going to be 1 gram per kg body weight is your ideal protein intake. In case if you're exercising more, or if you need to have more fat loss, we can go for good quality proteins of 1.2 grams per kg body weight. And as far as fat is concerned, restrict saturated fat, trans fats, and focus more on the visible and invisible fat, max up to 25 to 30%. So the total, following a balanced meal plan with good macronutrient composition. Apart from this, the micronutrients, there would be a deficiency of micronutrients. If there are any vitamin deficiencies, D3, B12, that needs to be addressed first, because D3 supplementation or B12 definitely needs to be addressed, especially if the person is a vegetarian. So in that case, if there is a B12 deficiency, that can be. And lifestyle management, if required, pharmacotherapy, behavioral management. Yes, I do give counseling sessions for my patients whenever they are stuck with the weight loss, because there is a plateau period after 3 months.
How much duration of physical activity per day?
Physical activity, see, for weight reduction, definitely what I have observed is they need to exercise at least more than 45 minutes of cardio every day. Now, WHO has mentioned like 30 minutes, 5 times a week is enough to have your balance.
That is a cardioprotective, I think.
Yeah,
for weight
that
loss,
is cardioprotective. For weight loss, you do more of strength training, endurance. So you do a mixture of exercises rather than sticking to just one cardio activity like Zumba. People with overweight, they go on Zumba and dance, and so that is going to put more pressure on your knees. Rather than that, stick to strength training at least twice or thrice a week. Endurance.
I think Dr. Rao also wants to comment.
Yes,
I myself, I'm into a lot of
physical
fitness,
activity.
and so I divide. When I tell in 2 minutes, I tell my patients, exercise you divide it in 3: aerobic, resistance, and flexibility. These are the 3 parts of exercise, which with a period of time, all these capacities go down. You become less aerobic fit, your muscle mass starts falling with time, and you become more stiff with age. So if you take care of these 3 things, so guidelines are at least 6 days a week aerobic activity, and at least 3 times a week some resistance. It may not be gym, but some resistance, simple body weight exercise, TheraBand exercise, some resistance exercise has to be there. In men, there is a new concept of male menopause now. We all start losing the testosterone levels after 30 decade, age of 30. The testosterone starts falling, muscle mass goes down by 1% per month, roughly 10% per year. Your weight will be the same, but ratios are changing. You are becoming more and more insulin resistant. Muscle mass has gone down. So you need to preserve the muscle mass by doing simple resistance. So resistance training is very important. And lastly, flexibility. So yoga, stretching will help. Any exercise you do, you have to start with some dynamic stretching, warm up and then post exercise. If you are doing good, intense, moderate intensity exercise, post exercise stretching, static stretching. So this will prevent injuries. Although people start some exercise for one injury comes and 2-3 months are gone. So always do and choose a good time to do exercise. Try to be consistent. That is more important.
Consistency is the key. Okay, now quickly, I'll just go through the next question. This is regarding protein. Since we are talking about weight loss, Anjali, how much protein per kg body weight would you say is recommended for weight loss?
For weight loss, usually we go with 1 to 1.2 gram protein. If it is, we need to increase maybe up to 1.5 gram. But of course, you have to see what if patient is having with the renal sufficiency or any other issues.
So who the patient is or client is very important, and then his entire history is very
again,
important.
You have to go with the detailed dietary, medical history, and find his biochemical lab, and then only. But usually 1.2 gram is a safe, and of course with the distribution of HbA.
Yeah, because now with so much of fitness centers coming, there are very unqualified people who are recommending lot of high protein.
I
And
can add here one
yeah.
few points, because in my OPD, so many years together I am seeing, but now over the last 5 years, the patient's history has changed, dietary has completely changed. I have seen few patients, they are not even eaten a carbs for 5 years together. Okay, and then they are land up with the raised uric acid, renal stones, GB polyp, and so there is a lot of clinical aspects of it. So we have to be more cautious about going for the
High
protein. 1.2 gram is the sufficient.
Okay, and what about supplements, Geeta? Do we really need to take it for an Indian? Because people say, we are Indians, we don't eat a lot of non-vegetarian foods, we have to have some supplement. Is it so?
I look first as total 15% of calories should be proteins in your diet. That can come to, you have to look at both. Your chapati rice also has proteins. First, work on each meal having 20 to 30 grams of protein in your diet as per your requirement, 10, 20, 30. Train the first patient to work on food aspect of protein. Supplements only pitch in when your requirement goes up. And I personally feel only if you're doing high intensity training, especially the weight training, or if you are recovering, or if you have any kind of illness, then the intake doesn't match your protein. Then the supplement, the name supplement itself says support your diet. So first, concentrate on including every meal 10 to 15 grams of protein, either way, higher vegetable, your cereal and protein. You do get from grains also. Then the high biological value protein, anyway, you're trying to work on 15, 20 grams. Then if required, you should go for supplements.
So I think 50% high biological value protein has to be always kept in mind and try to achieve it. Okay, now Ambika, quickly, there are different supplements which are available. There's whey, there's casein, there's soya base, there's BCA. And if you come across a fitness freak, he's got this whole lot of dabbas, carries a big bottle to the health club. So can you just tell us what are these different and how is the absorption different for each?
So as far as whey proteins, there are 3 types of whey. Whey protein concentrate, isolate, and hydrolysates. The best are hydrolysates, but hydrolysates are for patients like it's peptide protein. It is more for people with, small bowel issues or GI disturbances. So if a person is on a weight loss and he has some GI disturbance like IBS and all, whey protein hydrolysate is better. And that is also required only if they are doing, high intense workouts. Then whey protein is, advisable, because if you're doing a lot of workout and if you're not at all taking any kind of supplements, then it is not, and if you're a vegetarian for that matter. So as Geeta said, we first plan the diet as per the 1 gram per kg body weight. And in the small frequent meals window, we introduce protein in almost every alternate meal. So when you're taking protein, because of the specific dynamic action, the metabolism again increases. So there is weight loss. So this is about the whey protein. Then there are other supplements like BCAA. So when you go to the gym, the trainer immediately says, BCAA 5 gram low, aromatic, meaning they are like so confidently giving us the kind of supplements. And then they say vitamin C ek lena hai and salmon omega-3 ek lena hai. And isme EPA, DHA should be this much. And it's like, do you know anything about it? So this is the kind of trend which is happening outside. So we as dietitians, unless it is required, we do not have to prescribe unless there is a deficiency. Like, zinc is for taste buds. Sometimes it will increase appetite. The patient may feel hungry after taking zinc supplements. So you're putting them on a weight loss and they are going to be, increasing the appetite. So supplements need to be chosen wisely. Soya protein is good, like defatted soya flour can be used, and like natural supplements. What I would suggest is the natural form of fiber, natural soluble fiber powders. So these can be more, chosen than the chemically based formula.
Okay.
That's my opinion.
Okay. Dr. Javle, I would like to ask you, are there any, side effects that you might have seen, or, common side effects associated with high protein? Because when you see, these people who are going to a gym or who are into that, weight loss, they really go overboard in terms of supplements. They will not eat any carbs, only have protein. So what is your say about it?
I've asked his trainer has advised him to take 2 grams per kg, and he was around 60, 70. He was taking 140, 150 grams of proteins. In my practice, I have done biopsies for 2 patients who developed proteinuria, and only predisposition they had that they have taken these types of this way, so black color ke dabbe jate hain, and taking 2 grams per kg for years together. The basic pathology is whenever there is high protein diet, it leads to that efferent arterial vasodilatation, and there is an increased flow to the glomerulus, and which will increase the hyperfiltration and ultimately leads to proteinuria. Second thing, it will lead to that glomerulosclerosis. Once it is done for a longer period, there will be glomerulosclerosis, there will be derange in renal function, there can be increase in proteinuria. So high protein diet, especially those who are already predisposed to development of renal diseases like diabetics or hypertensives, those should ideally avoid. As madam said, it should be maximum 1 to 1.2 gram per kg. Only in some patients, like in our peritoneal dialysis patients, we advise them 1.5 gram per kg because they tend to lose so much from the peritoneal fluid. So though, I think that is only one I know where you can give more than 1.2 gram per kg of proteins.
So along with protein, the water also, sir. Basically,
water is
the
required.
amount of, so how much water you recommend, like, for the kidney patients, like generally when you give?
For kidney patients, like it depends on the edema, just like one slide has in between. So if there is swelling, less than 1 liter. If there is no if there is no swelling, and then as per thirst also we can give. And in dialysis, we have to restrict 500 to 800 or
Along with the protein
liter.
supplement, it's always recommended that water needs to be taken along with. So people take like 5 liters of water. If you see gym goers, they're taking 5 liters of water with 1 scoop of whey protein in the diet. So there's a lot of.
What about calcium? Is it like, the bone calcium is leached out if you're going to have a lot of, any doctor can comment on it? Calcium deficiency hote ka, hard tissue hotat ka if high protein asle तर?
Increased protein cause a lot of acidosis. Because proteins are amino acids, they are pro-inflammatory in response. So even 1.5, I have my own doubts unless it comes to a 15% bracket of your calorie intake. Because if you look at the calorie balance, your protein may go 40% also, because if you just have 2 scoops of whey, 5 eggs, and simple 200 grams of chicken or so. So definitely they create a lot of acidosis. And we all know that the maintaining pH balance is very vital to work on electrolyte balance. And if there's an increased acidosis, definitely calcium, magnesium, sodium, potassium balance can be a challenge. And that is why, end of the day, as I've said, we have to maintain what we have. If you start leaching out muscles, if you have leaching out calcium, you're at a loss with the nutrition supplement.
Okay. Yeah. Now coming to the next question, this is for Dr. Pawan. Sir, how would you differentiate between celiac disease and non-celiac gluten sensitivity? And what would be the diagnostic criteria for the same?
So celiac disease is basically wheat. It's a gluten. Gluten is gliadin peptide, which is actually causing allergy. It's an antigen which actually induces an inflammatory response in the GI tract. Most of the area, the target area for the damage is the villi of the small bowel, where you actually lose the villi of a small bowel, and hence the absorption goes down. And the people actually have the general complaints of both the gluten or non-gluten sensitivity. The symptoms are almost the same. You can't differentiate from up whether they have a gluten sensitivity, a celiac disease versus non-gluten sensitivity problems. So the problem will be GI symptoms like bloating, diarrhea, malabsorption. These are the common symptoms. Even extra-intestinal symptoms are common. Joint pains, and even co-existing problems like hypothyroidism and type 1 diabetes is common in these patients. So to differentiate between these two, the diagnostic criteria is a serologic. We do some blood tests. We see antibodies against gliadin peptides. We do TTG antibodies, DGP antibodies, IgA or IgG. This is what we do. And we do endoscopies of these patients. Endoscopy, we take biopsies from the duodenum and see if there is a loss of villi. We see if there is a villus and crypt ratio alteration. We see there are different things what we see in a microscopy. If serology is positive or an endoscopy is positive, it's a celiac. If serology and endoscopy are not contributing and still patient is responding to withdrawal of a gluten, his symptoms are going down, then this is a non-celiac gluten sensitivity. That's the basic difference between these two.
Okay.
Otherwise, as such, there are no criteria to define non-gluten sensitivity, non-celiac gluten sensitivity.
Okay, Geeta, any genetic markers that could be assessed for
this preventive approach of genetic testing? We are not looking predictive, but yes, there are HLA-DQ genetic tools. As Dr. Pawan had mentioned, that there is for a NASH, you understand the genetics behind the scene. So HLA-DQ can be understood to work on variations of your gene to learn whether you're gluten sensitive or you are prone to celiac disease. So once you understand the pattern of your gluten digestion through the genetic mapping, I think you can be more cautious. It's again a preventive measure to tell the patient that you have to control the wheat or you try to avoid certain foods because you're prone to gluten sensitivity. Or so that can be
probably
used
the
as
family or this next
Yeah,
generation.
so preventive genomics can be definitely worked out to work on gluten sensitivity.
Okay, Ambika, in short, again, can you talk about the dietary management for gluten-free
So
diet?
gluten-free diet, generally WROB, wheat, rye, oat, barley, we need to avoid for a gluten-free diet. So why oats? Because oats is generally contaminated with, gluten because it's milled along with something like that. So that is about the gluten-free. But how much of gluten is safe? So the wheat protein contains glutenin and gliadin. So gliadin up to 50 to 100 mg is safe, whereas gluten 50 mg, that is half a teaspoon of bread, can trigger a reaction inside. So that way, gluten-free diet, we allow all, generally millets are allowed, like rajgira. In the common terminology, jawar, bajra, all these which don't have gluten, they are allowed. Rice. Even if patients, sometimes they do have lactose intolerance, gluten intolerance, patients do have. So then we avoid even lactose and dairy products. Otherwise, the safe marker is just 50 milligrams is very, very less. And that can trigger the antigen antibody response. And it can last for some time too.
Okay. Now we'll move on to enteral nutrition. Dr. Thomre, we would like to understand what are the indications? When do you start enteral nutrition? And once a person is on enteral nutrition, any complications that or common problems that are faced, complications when it comes to enteral nutrition?
Enteral nutrition we consider in patients who are mainly slated for surgery. So the indication wise, I would say before surgery or perioperatively, and if the patient requires perioperative or preoperative nutrition, he is also a candidate to receive post-operative nutrition and even continuation even after his discharge. Now, most of the time when the patient cannot be fed orally and that oral feeding does not contribute to more than 60% of his nutritional requirements, that is when the enteral nutrition would set in. So most of the common conditions which will require enteral nutrition is road traffic accident with cranial injuries and patients with upper GI malignancies such as gastric malignancy, esophageal malignancy, or pancreatitis malignancy. And there are also like criteria which patients who require enteral nutrition. So anyone whose BMI is less than 18.5, who has lost 10 kg weight in last 6 months or maybe 5% weight in last 3 months, then patients whose albumin is less than 3 gram per deciliter, these are the patient, and the patient who has not eaten properly in the last or preceding 7 to 14 days is again a candidate for enteral nutrition intervention. Now, intervention by enteral nutrition is possible when there is intact gastrointestinal tract. That means patient is either not eating properly, either because of anorexia or because of obstructive symptoms, but there is no functional abnormality in the gastrointestinal tract. So this can happen in patient with esophageal cancer. So he's just not being able to swallow, but there is no problem with the digestion. So these are the patients in whom we need enteral nutrition. In ICU, most of the critical patients in whom there is anticipated no enteral feeding or oral feeding to be established in the preceding 5 to 7 days, you can start your enteral nutrition. Now there are a lot of many myths, and of course they have been given away. You don't require NBM status in patients who are undergoing surgery. So patient can take liquids up to 2 hours before surgery, or solid foods at least 6 hours before surgery. And most of the patients, you can again resume nutrition within 24 hours of doing surgery also. But you did not achieve this goal on the very first day. Even if you are able to achieve this full nutrition, the total requirement in the forthcoming 5 to 7 days, that would be okay. So need not hurry, gradually increase on the nutrition value of these patients. And enteral nutrition means most of the time they are basically artificial nutrition formulas. So they need to be mostly given through tube feedings. And the best is nasojejunal tube, because that can be done endoscopically and can be placed in the distal tract, that is the proximal jejunum. Your tube should be there. And of course, there are ways and means to give the feeding also. Now, the most common is tube placement problem. So you have to make sure that your tube is in the gastrointestinal tract. That means you have to confirm the position by aspiration of bile. And these patients, they have risk of aspiration. That is one of the common problem. So you have to give at least nutrition when the patient is having 45-degree inclination of his chest or the upper body and this thing. And initially, of course, as I told you, you are better off giving drip feed. If you give bolus large feeds, then these patients will have crampy abdomens, distension of abdomen, maybe abdominal pain. So, and another most common complication is lack of hygiene. So hygiene has to be observed diligently when giving enteral nutrition, because this patient most common complication is diarrhea. That is also contributed by the medications, antibiotics that the patient is receiving. And constipation is another complication, but it's not an immediate complication. But if you go for a longer period of time, then because of lack of fibers, these patients will have constipation. Then other complications also include induction of ischemia. So there are some contraindications. If the patient is in shock, don't give feed. If the patient is on high dose vasopressors, don't give feed, because that can induce something called as non-occlusive mesenteric ischemia, and that can lead to bacterial translocation as well as deterioration in the patient's general condition. So there are very few absolute contraindications. The patient who is obstructed, who is perforated, who is having mesenteric ischemia, or who is actively bleeding, these are the patients whom it is contraindicated. So these are the most common complication. Again, the common complication is like refeeding syndrome, and that usually described with parenteral nutrition, but can also occur with enteral nutrition. The tube patency is another common problem. Most of the time, the patient or the patient relation, they don't understand the value of tube flushing. So most of the time, we tell them to flush the tube at least by 50 cc of tap water, and that clears the tube and does not form a curd formation in the tube. And obviously, tube patency will lead to regular administration of this enteral nutrition.
Sir, you've almost covered the pre-op dietary management. There was this case for the same. A 28-year-old male has a history of abdominal pains in 6 months. Evaluated OGD, colonoscopy is normal, treated as APD and colitis multiple times. He has lost 10 kgs in the last 3 months. BMI is 18. Vomiting is there. I'm sorry,
I'll just tell.
Yeah.
He knows the case. We operated this patient recently. The same patient, sir, who's having Crohn's. We did RA. So this patient has multiple bowel strictures. He's vomiting. He's only tolerating liquid diet for last 2 months. His labs are HB is okay, but albumin is 2.9, globulin is 1.3. LFT, RFT electrolytes are normal. So we are planning an exploratory laparotomy resection and anastomosis to this patient. And with these parameters and with this history, how would you manage the diet of this patient pre-operatively?
Yeah. So this patient actually has all the criteria, most of the criteria for nutritional intervention. Now, whether enteral nutrition is going to help or not, totally depends on whether the GI tract is functioning and patent. So this patient is having subacute obstruction, I would say. If he develops absolute obstruction, obviously enteral nutrition cannot be used. But if there is subacute obstruction, you put the Riles tube and the obstruction is taken care of, then you need to have intervention, nutrition intervention. So I would give this patient at least 7 to 14 days. 14 days is too much from the cost point of view, but of parenteral nutrition, because there is no emergency. You tackle the obstruction by putting a Riles tube and the emergency becomes elective in this patient. Now this patient has question mark in the sense whether his diagnosis is Crohn's disease or intestinal tuberculosis. Crohn's disease, most of the time, these patients, they have a lot of weight loss. Of course, there are some criteria which describe what is more predominant or whether Crohn's disease is more likely than intestinal tuberculosis. But anyway, this patient has obstruction. So I think differentiation would not help much whether it's Crohn's or tuberculosis, because he is obstructed. And these patients, again, you need not give them in parenteral nutrition the whole requirement in one go. You gradually increase, step up the requirements. And of course, you at least insert a central venous catheter for him, because peripheral catheters will only partially supplement him. And you need to keep on changing the catheter site every 24 hours because of phlebitis. And there is limitations to the amount of nutrition you can give through the peripheral catheter. Now, this patient was operated and his diagnosis is Crohn's disease. And he had at least 15-20 strictures in the terminal ileum, just 2 to 3 inches away from each other. So we could not conserve his bowel, because if they are distantly placed, you can conserve the length of intestine by doing stricturoplasty. But here doing stricturoplasty just 5 centimeters away from each other, and that too 10, 12. So he had lost approximately maybe 1 meter of his distal small bowel, and he had distal or proximal ileal anastomosis to the terminal ileum. Of course, his colon is intact and there is no Crohn's disease in the colon. Now, even in the Crohn's, you need not resect, because first surgeon will have some liberty. He might resect, but the second and third surgeons will not have liberty, because you don't know. This is a recurrent disease. It will recur if it is a Crohn's, and every time you cannot go on resecting. Otherwise, this patient will land up in short bowel syndrome or what is called as intestinal failure. So aim is to preserve the length. Now, on operation table, there are some indicators, whether the ileocecal junction is involved or not, what is the lymphadenopathy size, and what is the fat cribbing and the location of this thing. So to some extent, on operation table, you can still be able to differentiate whether it is Crohn's disease or intestinal tuberculosis. Now, in parenteral nutrition, obviously, we will all go for what is commercial formulations, and with addition of electrolytes and trace elements as per the patient's requirement. Now you get various bags which are 1000 ml, 1500 ml, 2000 ml. So you can also vary the total amount of nutrition these patients receive. And obviously, total parenteral nutrition containing olive oil, fish oil, they are preferred over now totally predominantly plant-based, that is soybean-based total parenteral nutrition preparations. And also you get variations in amount of protein and the carbohydrate ratio. Sometimes the protein ratio is around 20%, the fat ratio is around 30%, and the 50% is carbohydrate ratio. But if you are giving for long term, then you have to think of this composition. If it is only for 7 days to 10 days, you need not worry about the composition wise. Usually they have standard formulation 2:3:5.
Okay.
And the complications are there, but I think the most again is immediate complication, that is placing the tube. Second thing is hyperglycemia. So you need to monitor frequently for blood sugar levels. Again, there is complications of refeeding, so that you have to be taken into account. And another complication for long term is basically thromboembolic events occurring in the large veins. And there are another long term complications like biliary complications, hepatic complications, and renal complications. But these are observed with very long term parenteral nutrition, and largely many of these patients are actually on home parenteral nutrition.
This is the last question that we are having, but I just summarize what sir is trying to tell is that these kind of patients, malnourished patients, we should not be in a hurry to operate these patients, because the problems that they will face after surgery is leaks and wound infections are much more difficult to manage than managing them nutritionally preoperatively. That is the take-home message I would like to give.
Okay. This last question is for Dr. Rao. See, normally in pregnancy, we always consider the pre-pregnancy BMI, and then we plan, or you suggest how much weight gain. In a GDM patient, how do you go about the pre-pregnancy BMI and weight gain? How is it related? I mean, what is the guideline?
I don't stick to any guidelines here.
Okay.
My personal observation is I've seen mothers who have gained 20-25 kgs in that 9 months, GDM mothers, and they have delivered babies less than 2 kgs, and mothers who have gained hardly 5 kgs and babies 3 kgs birth weight. So I don't think weight gain in pregnancy is the real crux. It's the nutrition, the balanced nutrition and the glycemic control, which is important.
Okay, so how about we say how is the blood sugar level or HbA1c and then weight gain? Do you at least, in case somebody's sugar level is high or the HbA1c is on the higher side, then what about weight gain?
It also depends on the medications that we choose. Metformin, if we choose, the tendency of weight gain will be less. The mothers tend to gain less weight with metformin in that 9 months. Okay. With instant to gain more weight. So there are no fixed criteria, but I always say keep a balanced nutrition, be in touch with the nutritionist, and keep daily monitoring of glucose has to be daily in pregnancy. I see many patients in Western countries who come for delivery here, they see 4 to 5 times every day.
Okay.
But that's very important. Keep monitoring the glucose, balanced diet, and as needed, we have to update the medication dosages every 1 or 2 weeks. So we call them at least once in 3 weeks. I call all my patients, but I don't stick to any weight gain criteria as such.
Okay. Ambika, last question now for today's session. What about the dietary guidelines for GDM?
Yeah, dietary guidelines, actually we plan it as per the weight only. So the BMI, if it is between 18.5 to 25, that is the BMI range, the weight gain can be 12 to 16 as per the Institution of Medicine Gestation Diabetes guidelines. And if it is about 25, the BMI about 25, the weight gain is 9 to 11. So, and if it is above 32, that is morbid obesity or grade 2, grade 3, then 7 to 9 kgs is what is the maximum weight gain allowed.
So I think we need to consider the Asian BMI.
This
so
is
23
Asian.
would be cut off, right?
Yeah, so this is the Asian guidelines. Then apart from this, a 5 kilo, generally HbA1c drops by 1% when there is a 5 kg weight loss in normal diabetics. So in gestational diabetes, if there is a enormous weight gain, so we need to retain, not to at least lose the weight in the 3rd trimester. If it is, then we need to maintain. Or if it is in the 2nd trimester, we actually help the patient lose little bit of weight, 2-3 kgs with complex carbohydrates. And generally we follow DASH diet. That is the regular Mediterranean, and DASH diet is what is recommended for GDM patients.
So basically, I think monitoring is very important. As you said,
prevent
monitor the
maternal
blood sugar level,
hypoglycemia, right,
as well as monitor the weight gain in case it's already on the
optimal
higher
fetal
side.
growth, and prevent macrosomia because large babies are, so because of the weight. So that is one criteria which we actually follow.
Okay, I would like to thank all the panelists. We really had an excellent session. The thing that we, exceeded the time itself says that, everybody was enthusiastically participating. I'm sure the audience also benefited. And I can see the audience has started becoming hypoglycemic. So I think we should end the session. Time for nutrition.
Thank you all the panelists and Shilpa madam. Now we would be doing the felicitation. Can we just have everybody just wait up here, please, for 2 minutes? I would like to call upon Dr. Raju Varyani, Dr. Alka Shirsagar, and Dr. Gitanjali Sharma to felicitate the panelist and the moderator. Let's start with Ms. Shilpa Shirore. Shilpa madam. Mrs. Anjali Kirkar. Mrs. Anjali Kirkar. Dr. Mahesh Thomre. Now the panelists, Dr. C.R. Rao, Dr. Pavan Hankare, Dr. Meenakshi Deshpande.
Anjali Kirkar's felicitation is remaining. Anjali Kirkar, madam.
Dr. Pavan. Dr. Sunil Zaure. Dr. Sunil Zaure. Dr. Meenakshi Deshpande. Dr. Mahesh Thomre. Dr. Geeta. And Dr. and Mrs. Ambika Nair. And Dr. Kedar. Okay.
Already, we'll just have a group photo.
Hello. I request Dr. Meenakshi Deshpande to felicitate Avanti Deshpande. Yeah, she's certificate. Yeah. She has compared.
She has done a fantastic job last minute comparing. Thank you so much. Yeah. I would request our today's MMC observer, Dr. Padma Iyer, madam, if she could come up. I would also like to request Signutra company, nutrition company people to come up to the stage and request Meenakshi madam to felicitate them. Vida Slim is the product, and I am sure those who require can have some samples outside. I would request all delegates, those who wish to have photographs with the certificates, to come on stage and take a group photo with all of us. Otherwise, also they can join on stage. Please do join. Lunch is served on second floor, Kelkar Hall. After the group photo, I'd request Gitanjali madam to have the vote of thanks. If all could, please do join for group photo. Those who want to have their certificates can collect it here with, along with the group photo.
You can stand here.
हॅलो बरं त्यांच्या नावाप्रमाणे आहे सर्व डेलिगेटची नावं लिहिलेली आहेत सर्टिफिकेटवर त्या तुमचं सर्टिफिकेट घेऊन जा दुसऱ्या कोणाचं घेऊन जाऊ नका
Before we all disperse, vote of thanks. Thanks to IDA convener, Mrs. Shilpa Shirole for taking it forward. Ambika Nair for coordinating. Avanti Deshpande. Could you just please have a minute of silence? I won't take more than a minute. All people need to have their due credit. All the, all the conveners from IDA, the executive committee members from Varyani sir. IDA executive committee members, conveners, IMA managing committee members, office bearers, IMA CGP sub faculty, Dr. Sancheti and Dr. Raju Varyani, our event coordinators from IMA, all the ground staff, Dipen, who's done a fantastic job of transmitting it online, Mr. Sunil Miraskar, who's our, the technical person today who is transmitting and capturing this. Of course, it goes without saying that delegates who have attended in large numbers have made it interesting program. And once again, thanks to Mrs. Padma Iyer Madam, who is our MMC observer today. All the delegates can collect their certificates from here. And with this, I think I can close this event. Thank you all. Thank you very much. If I may have missed someone, please excuse me.